Put the banner.
I'll just give you the link.
I can't. And also make me co-host. Let me see. But okay, make me host for a minute. Let me see. You've gone YouTube live on the same link? Okay.
I'll send you the link.
Okay, got it.
I made you the host also.
No, you've gone on. Okay, yeah. Okay, good. I got it.
Ortho TV only.
Yeah. I got it. I got the link. Hi, Mir sir. You're muted. Your audio is not connected, I guess.
You can hear me now?
Yeah, now we can hear you.
Yeah. So all well at my end. How's yours holding up?
Yeah. Good, sir. Good. Hi, Vishal. Connecting audio. Vishal, you are sharing the screen?
I am doing it.
Okay, just share the flyer. No? Hi, Vijendra sir. Your audio is muted, sir.
It's on now.
Hi, sir. We can hear you now.
I like your background, Ashok.
Thank you, sir.
Is this real or one of those?
It's virtual, sir.
Virtual. Very nice.
Yes. So I am with Dr. Ashok. Ashok, Dr. Gautam is online. We'll have to allow him to join in.
Yeah.
Ashok, Dr. Gautam Chakravarti.
Yeah, sure.
Yeah, sure. Sure. Yeah, now you can try now.
Sai, give me the co-host thing.
Sai, allow Ashok to host in, please. Welcome, Dr. Bala.
Yeah, good evening.
Hi, very good evening. We should be starting in like 10 minutes from now.
Oh, perfect. Yeah, sure. Thank you.
Yes, Dr. Gautam.
Hi, Ashok. Gautam here.
Hi, Gautam sir. How are you?
I'm good. Thank you.
There are many people finally joining, so we are just looking.
Okay, no worries.
Hi, Ashok. Can you hear me?
Yes, sir. Hi, Girish sir. I can hear you.
Hi, Girish.
Hi, Gautam. Good to see you.
Good to see you, man. Good to see you.
All well, I hope.
All is well. We are very busy at the moment. My hospital is just beginning to get hit.
Oh dear. Take care.
we are just facing, it's coming up from London. So we were 2 or 3 weeks behind.
Have you got all the stuff in place? Have you all been deputized to take COVID duties then?
Yeah, kind of. I'm the CD, so I've reorganized my entire workforce and trying not to get involved in direct CD, but we have taken over A&E. We are
Okay.
running the minor injury center from 10 in the morning to 10 in the night every day. We still have a steady stream of neck of femurs coming in every day. That number hasn't really gone down. What we have seen is the kind of regular 4 or 5 ankles, olecranons, that kind of thing. But this weekend was a good weekend. The sun was out. So today we have seen a lot of distal radius fractures. But we are running a virtual fracture clinic every morning with 2 consultants and with somebody who's self-isolating at home because of his medical conditions and running the service like that. So we see them. We have got now got a plaster room service every day from 10 to 10. All those things, and we are presently running it on 1 site only, but the management wants us to do 2 sites, but that is quite difficult actually. I don't have the workforce numbers.
Yeah,
And I've seen my juniors just
to join in, Gautam, because this information is very useful for us as well. So it will be a great thing. Just hang on. I think once Ashok gets everybody on board.
yeah, absolutely.
Yeah.
गौतम घर में बैठा है तू क्या? म्यूटेड है.
हाँ, घर पे बैठा है.
ले साला
क्या करेगा?
यही होता है ना, बड़े लोग घर में बैठ के सब हमारे जैसे छोटे लोगों को काम कराते हैं.
I'm not out of choice, unfortunately.
I know. तू क्या शील्डिंग में?
हाँ.
Okay.
In fact, it is worse sitting at home because you would twice the amount of work to do.
Super sir is here. Afternoon, sir.
अरे वो कुमार आया क्या? अशोक?
Not yet.
He was trying to join early on. Let me get him.
Okay, yeah, I'm just checking in. Samir Dalvi.
We have Dr. Avinash Supe with us. Dr. Avinash Supe, welcome, sir. We are just going to start in like less than 10 minutes from now. We all wholeheartedly welcome all the panelists around. Please bear with us. The idea is to have all the panelists on board and then we go and start the webinar there. Just to keep you all informed, we are going to be relayed live all across the India and also abroad. We are going to have more than 5,000 participants hearing to this conversation, and there are many questions that are going to come across. We have a wide board of panelists with us to have a wide variety of opinions and suggestions. Hopefully that may in coming future get converted into guidelines and hopefully into recommendations for the safety of all, not only manpower involved into healthcare, but also people who are out of healthcare, making this world a safer place in coming times when lockdown is over. So welcome you all panelists. We'll just wait on for a couple of more minutes before we really start in.
Sure. Hi, Bala, can you hear me? Bala, this is
Yeah, I
Abhay.
can hear you.
Hi.
Hi, Abhay. How are you?
Very good. Good to see you. You
Yeah,
know the
good to
kind of
see you.
stuff we want from you, right?
I got a briefing this
Yeah.
afternoon.
Basically,
from
what has
Vishal.
changed from getting a patient from the casualty to the OT table? What new
Okay.
things have you introduced in the light of the current situation?
Yeah, sure.
That's
Yeah.
more or less. That's what.
Okay. Okay.
Lovely.
Hi, Abhay.
Hi, Anand. Nice to see you. The whole bunch of Brits there. Dr. Bijendra Singh is there, and Dr. Chakravarti is there. So three Brits. Hi, Gautam. This is Abhay. We met sometime in.
Hi, Abhay. How are you?
Lovely to see you.
Same here. Hi, Anand.
Hi, Gautam.
How are you
Hi,
doing?
everybody.
I'm fine, thanks.
Good.
You okay?
Dr.
not bad.
Nilen is here. Hi, Nilen. Good
Hi,
to see you
Abhay.
free outside the OR for a change.
अरे नीलेन तो हंस रहा है क्या बात है
Gautam, nice to
Nilen
see
is-
you.
Nice to see
We
you,
also have
Nilen.
Dr. Kumarwell. We also have Dr. Kumarwell. Dr. Bala, Dr. Kumarwell from Australia, Melbourne University. I think Dr. Kumarwell from UK. He's also anesthetist, chief anesthetist in UK, and he's also joining
very
us
nice.
from
Oh,
anesthesia
excellent.
perspective. Yeah.
Oh,
Excellent.
lovely. Lovely.
He's
Dr.
from
Kumar.
my
Dr.
hospital.
Kumarwell is there already with us. He's done.
Kumar, all okay?
Yep, all fine.
गाली वाली कम देना कुमार.
Who are the people who have been operating?
Trauma
Trauma. When I
only.
yeah.
Well, we've been operating trauma, urgent cancer, emergencies, and a few other bits and bobs.
Okay.
I mean, that's going to be the key discussion, right? What do you call an emergency, and who calls the shots? And is there because typically at our place we guys choose, and it goes through a very kind of a very unsteady hierarchy, if you may. There's no one to kind of put the brakes on the surgeon's aggression for calling a case an emergency.
Yeah,
And that's what I think we need to.
That's the big difference between the Indian medical setup and the NHS. The NHS is very clear about a few things, and I know there are inter-hospital, inter-trust variations depending on the size of the trust, the locality, and what the tertiary element of the trust is. But for a small trust like mine, we've got some completely different plans and things that are going on. And we are a split site trust as well. We've got to offer services across 2 hospitals, albeit 6 miles apart. So we'll pick that up as well.
Good afternoon, everyone. Samir Dalvi.
Hi,
from
Samir.
Mumbai.
Welcome, Samir.
Hi, Samir.
Hi, Samir.
Hi, Samir.
Dr. Supe, hi. This is Abhay Nene. I'm one of the co-moderators. We were going to pick your brains on, on whether some private hospitals are putting themselves in the line of fire in our city by, allowing COVID patients. Because there's a high, the way our system is working is that you find one positive patient and they just block the hospital.
No, वो वाला room नहीं sir. वो वाला room में नहीं जाना है. अपना regular 645, 649.
So we'll want to pick your brains on that, and where the public versus the private sector stands, and there's some thinking that some guys are pulling the plug and saying we're a COVID positive hospital, we have to stay out quarantine so that they don't get in the mess. Anyway, Vishal is here, so Vishal, you can take over.
So we are just waiting for our co-moderator, Dr. Ram Chadha, who's going to join us in a minute's time. Also, Dr. Praveen Amin is going to join us. We have a host of our panel with us, and this is the best panel one can ever imagine. We already have with us the lovely, gorgeous, the only lady with us who's going to really control all these horses around from going out of bounds, Dr. Amita Nene. Hi, welcome, Dr. Amita. We also have this is like the broad panel, and I was told why should we have such a broad panel to discuss on an issue of COVID. So let me just introduce the whole point of having this wide a panel. We are all affected by this, and I think 70% of orthopedic practice is not dealt in Mumbai, is not dealt with by corporate doctors, is not dealt with in organized sector. It is actually dealt with by people who are in clinics, who are in nursing homes, small hospitals, big hospitals, government hospitals, and a bit of it is being dealt with by us. Unfortunately, in this tiring times, none of us know exactly what is going to happen after the lockdown is open. We don't even know what is happening today. And that is why, to get some answers to many questions that we must have, we are also going to be poured in by questions from all across the country. We thought of having who else but administrators, and we have Dr. Avinash Supe, who can represent both the best of the worlds from government hospitals also, and also from the corporate hospitals. He is the executive director at Hinduja Hospital, Khar currently, and also has been the ex-dean KEM Hospital, Mumbai for a very, very long period of time, and has successfully brought in changes for the benefit of everyone. Welcome, Dr. Avinash Supe. On the behalf of Bombay Spine Society and all the orthopedic fraternity, we welcome you here, sir. We also have Dr. Rajan Sharma, who himself is an orthopedic surgeon, is involved into a lot of policy making. He's been sitting with the strategy consultants in Delhi. He is a president of IMA and is going to help us understand what the government stand is currently and how the policies are going to change in coming times. In this ever-evolving scenario, I am sure a collaborative effect by orthopedic fraternity, IMA president, and suggestions from the orthopedic fraternity are going to make a big difference. Welcome, Dr. Rajan Sharma. We have hospital owners who have their own concerns. Their hospitals are lying vacant. They are ready with their manpower. Their outflows are ongoing, but the inflows have come down. That the very word of whether they should become a COVID hospital or they should stay away from being a COVID, they are still not aware about. The outflows continue. How long will they be able to sustain the financial losses? How long will they be able to manage the professional chaos? And how to reroute the current level of manpower to make a surgical change of rota is also a major concern. We are going to discuss with none other than Dr. Parag Sancheti, the owner of Sancheti Hospital Orthopedic Center in Maharashtra. We also are going to be shortly joined by Dr. Rajashekharan from Coimbatore. He's currently into a strategy meeting in Tamil Nadu with the district collectors there. We also have Dr. Tushar Agrawal. Welcome, Tushar. He's the owner of a nursing home in suburbs of Bombay. And we, to represent the other part of the country, we have Dr. S.N. Saraf, who runs 3 big hospitals in Bihar, a small one, a big one, and a very, very big one in Patna. Welcome, Dr. Saraf, to discuss with us about the preview about the effects and the impact of Corona and COVID on the hospital owners. Who other than the consultants here in Bombay, consultants in city of Bombay, Mihir Bapar, Devnani, Hetal Chiniwala, all, and apart from that, Appaji from Chennai, Ranjit Unnikrishnan, Neeraj Vasavada from Gujarat. Please join us. I really welcome you all to share us about the effect that you have gone through, how the practice has evolved before Corona, after Corona, and now with Corona and with lockdown. What do you anticipate to come up in future after the lockdown is over? The real game is not with orthopods. We are all people who just assume things and believe that we are the best of the mankind. Unfortunately, we are nowhere because the brain lies really far away from bones. And where the brains lies, we have the 2 most important and the most strategy guys who are going to help us to understand what we should do actually on the ground when we take up these patients. Pre-operative evaluation, how to get them fit, how to understand whether asymptomatic carrier has to be taken into OT or not, whether it is risky enough or it is safe enough to take a COVID positive patient or not. We have Chief Intensivist, Bombay Hospital, Dr. Praveen Amin, and none other than the gorgeous Dr. Amita Nene, who's a chest physician at Bombay Hospital, going to enlighten us about what to do and what not to do about these patients when we deal with asymptomatic carriers versus high suspects versus real-time COVID positive patients, if surgery is required in them, positive patient and whatnot. And if surgery Yeah, we are going to talk about that as well. Yes. And then we have we have Dr. Bala Venkat with us, and also Dr. Kumar Vel from UK. They are the chief anesthetists who are in Bombay Hospital and in UK. They are going to tell us about what precautions one must take while taking up any of the emergency surgeries today, or if we are planning to come up with elective surgeries in coming times. We actually don't know how to reduce the risk involved, not only to anesthesia professionals, but also to the healthcare workers inside OT, all the orthopedic surgeons, and also the nurses, the staff, how to reduce the impact of COVID-19 so that we can actually preserve these resources for all the tiring times. We all must understand that lockdown may get over in a small while. However, the corona is here to stay, and the new normal standard will have to be formed. I'm sure we are going to see much more in coming times. Dr. Bala and Dr. Kumar Velam, we welcome you all from Bombay Spine Society. And all this, when we are discussing, we are still 3, 4, maybe 5 weeks behind some countries like Europe, UK, and Australia. Let's hear from them. We have a big team from UK to share the experiences of what they have gone through, what were their sufferings, what are the guidelines they are following, and what is the current state of impact of COVID on orthopedic practice. Have the indications changed? Have they actually started doing emergency cases, or have they actually started optimizing the treatment even for emergency patients? To hear out, we will be having with us the president of British Indian Orthopaedic Society, Dr. Brijen Singh. We also have the past president of BIOS, Dr. Gautam. We have Dr. Anant Tambe, senior spine surgeon from UK, and we have Shivan Maria, who is a junior consultant in NHS, again to join us. We also are going to be joined very soon by Dr. Meenu Patel, who at a very short notice has agreed to come and share his experience from Australia, where the situation is little better than the other countries known around, and they've been able to curtail it, and the services are really picking up. They have actually started entering into elective surgery. So we have all this panel today and much more to come up. We have Dr. Ram Chadda here. Dr. Ram, are you there with us already?
Yes, very much. I'm here.
Welcome, sir. So the format is going to be that me, my senior Dr. Abhay Nene, and his senior Dr. Ram Chadda are going to be moderators for the day. And we are going to have questions to understand if you have questions or answers to our questions. And if you have answers to our questions, would you like to frame them to be called as suggestions? Would you like them to be becoming the recommendations? And if at all these are already recommendations, would you mind recommending to the policymakers, the administrators, so that they can take it up and make them as guidelines in official days to come? Dr. Ashok, may I have an opportunity to share my slides from here, please?
Yes, please.
Dr. Ram, your opening comments on that while we go in.
Welcome, dear friends from overseas and from India. Two of my classmates whom I have not connected for a long time. A special hi to both of them. Gautam Chakravarti sitting in Huddersfield and Meenu Patel sitting in Melbourne in Australia. And looking forward to catching up with these guys someday soon. Well, we are going to have a discussion based on what Vishal has already suggested. We are going to look at inputs coming in from people who are in the thick of things. We as orthopedic surgeons felt that we would be the last men standing. However, the orthopedic fraternity has been hit and hit very hard in our country already. We are going to discuss the present situation and the way forward in 3 webinars, one happening today, the next happening on Thursday, and the last happening on Saturday. We would, as of today, look at situations of the present. We are not going to discuss anything about how are we going to look at the post-COVID situation when we get back to work. Today, we are going to discuss how things were till a month back, how they have suddenly hit us today, and how are we going to go through the next few days or few weeks in our practice. We are not looking far, far forward as to what the new normal would be when all of us get back to regular work. So that's where we are. So I'd request each one of you to put on your thinking caps, give us the evidence, give us the expertise, and share your experience. Thank you very much for joining us.
Thank you so much, Dr. Ram. So here we go. COVID-19, it's already a 6-month-old baby. We hate him. We really, really hate him. Unfortunately, it has spread so fast. We already have 1.5 million plus cases already. 1.5 are dead. 1.5 lakh are dead already. In India, the numbers are only growing. How fast are they growing? We all know already. 1st April, we were only 2,000 cases, looking very positively that the lockdown may get over. And the news is that tomorrow, Mr. PM is already going to address all of us. And I really wish everything gets settled down tomorrow. Unfortunately, the picture is looking grim, that in only 12 days, we have grown 4 times in numbers. It's only going to grow. Lockdown may get over. Corona may not. We are surely going to find some new normals for every fraternity. Here we will speak about orthopedics, how the orthopedic services are going to be hit. Currently, what are the levels where we are, and how and what ways can we be prepared to resume the services. We all have learned this lesson in a very hard manner. And unfortunately, we have seen some healthcare workers not only getting affected, but dying. We all know now. Don't think that it cannot happen to you. And that's why safety is paramount. On one hand, social distancing and lockdown is the answer to it. On the other hand, we also want that while practicing safety and precaution, we also want to get back to our normalcy. We don't want situations like this cropping up. We don't want infections. We don't want critical illnesses. And we surely don't want to see deaths neither to our colleagues, to ourselves, and to any of our patients. We want the infection to be controlled. We want services to be resumed. We want at least the emergency surgeries to start off. We also want the subspecialty services to get back online, but we don't know how to continue. We don't know nothing actually about it. We have so many assumptions, so many questions, and answers we don't know. All these questions and much more today. Let me catch up on some of our very, very eminent panelists today, and we are going to be just grilling across, only bringing our set of questions, and we would love to hear many, many more questions if you have in your mind, rather than coming up with answers only. Dr. Avinash Supe, let me have you with opening comments from you, sir. In this grueling scenario, you have been the guy who has shown the light to all the government hospitals in past. Can you please enlighten us, what is the actual burden of Corona on healthcare today? How do you foresee the public hospitals being overburdened or private hospitals being burdened in current scenario?
Sure. I think if you really look in situations in Mumbai and Maharashtra and in India, the 3 levels, if you really look, what has happened in Mumbai, public hospitals today are overburdened because many private hospitals are not doing even emergencies like deliveries, LSCS and other things, trauma. So they're all being shunted to the public hospitals. Private hospitals, as you know, almost about 15 private hospitals have been found a COVID patient, which is therefore they have been underworking. While there are some hospitals have been converted into a COVID hospital. So if you really see, the systems are already stressed because there is an overburden on the public hospital, and private hospitals are also limited are working. Now, hospitals empty, yes. I think that's the biggest concern for a hospital administrator, to balance between the number of patients and safety of our surgical force. The priority should be to the safety of the surgical force and our patients. And therefore, everybody is trying to save energy by trying to do minimum surgeries at this stage, so that we will be able to save the energy. And therefore, everybody is trying to do that. And as you know, elective surgeries have grossly come down. And this is recommendation of the most of the guidelines, whether it's an Indian Orthopaedics, Indian Surgical Gastroenterology, or everybody. Nobody wants to do elective surgeries, but definitely emergent, urgent, acute, all these are being done with lot of care. Patients are shunted sometimes from one place to another place. But if they find that there is a good PPE, surgeon is there, anesthetist is there, these are being done, but the numbers are very low. Now, a difference between COVID and non-COVID hospital is, about a month ago, it was definitely there was a COVID hospital was differently prepared and non-COVID hospital was differently prepared. Today, we are seeing patients with atypical kind of an presentations, and we should consider every emergency patient who comes to us, and we should do universal precautions, and we should try to see that every patient is treated with COVID safe kind of an PPE. Now, the level of PPE may differ, but conceptually, I think every hospital who is treating patients, whether even if you are doing something like a fracture, I feel you should try to see that in an operation theater and managing patients, you use some kind of PPE, and in operation theaters, full PPE, so that you and your whole staff is safe. And that is had changed over last 1 month. And I think last 2 weeks, since the cases have started coming up into different kind of ways, like somebody is getting to us with neurological symptoms, has a COVID positive because of the microthrombi. Somebody is coming to us with hematuria because of the D-dimer kind of a change. So these are all effects of COVID which are seen on other systems other than respiratory. So such patients come to us. I think we need to be prepared, and therefore this everybody should use now the universal precautions, and that is my, I think, worry. Another thing which is coming up is the lot of people are going into quarantine because unplanned exposures, and therefore the health workforce is reduced into private sectors. Public sectors also it is reduced. There are something like hundreds of doctors in public hospitals are quarantined, and therefore you will find that we are not able to really run the exactly services which is there, and that is the whole perspective we have to really give. Now, what is the risk of locking down? It's an economic loss. I think that is the biggest loss. Secondly, the transport and the shifting from the peripheral hospitals to public hospitals has also increased, and the services like super specialty and elective have really gone down. I don't know whether anything else you want from me.
Yeah, I think thank you, Dr. Avinash, for making very clear that the hospitals are already overwhelmed with the services that they have getting are providing to the patient with COVID. And you also mentioned about two things about efficiency of human resources. You want to cut down on more and more of elective work. You only want to keep the human resources so that the future we can be more future ready. So is there any assumption? Is there any thought that you think that the numbers are only going to rise? India is already getting so aggressive, and we hope that the peak may soon be over, or it may just be seen very soon. So what do you, is there any assumption that the numbers are only going to grow from?
There are different articles and different reports have come. If you look from John Hopkins report to Indian report, they are totally different. Now, as per the John Hopkins report, which came 2 weeks ago, today we should have 25 lakh patients. But maybe we don't have that. We have still about 8,000-9,000. Even if you say there are equal number detected, we still have about 16,000 or 17,000 patients. Now, the numbers are definitely less because of many factors, but I'm sure it is going to increase for some time. Now, if you look at the previous experiences, if you look at, say, Spanish flu or previous flu, there always have three kind of peaks which come. And what we are doing is we are trying to flatten the curve. So the curve is going to go longer. So we'll have an initial kind of an peak for about 3 months, then a little bit low down, then again it might rise. And this may get prolonged for October or November or maybe more. That's what I think. The low level of COVID is going to remain all the time. There may be surges in between. That is what is the prediction of the world.
Right. Dr. Praveen Amin. Right. Thank you, Dr. Supit. Dr. Praveen Amin, you have been very, very closely involved along with Dr. Amita in designing the concept of isolation wards in various hospitals, including Bombay Hospital. What's your take on that? There are some hospitals which are called so-called COVID hospitals, and there are some hospitals which are non-COVID hospitals. For us as orthopedicians, we don't know when we get an emergency patient, which hospital should we actually choose if the patient is not worked up. Can you please enlighten us? Dr. Praveen Amin.
See, hi Vishal, thanks for having me here. A point of order that we need to understand is that this is a new order that we are seeing in this day and time. The kind of disasters we are seeing in the Western world, which can translate, if that translates into our part of the world where the medical services are limited, we are going to be in for a major catastrophe. If you see what's happened in Italy, and if you see what's happened in Spain and what's happened in the US currently, especially New York City. So the lessons that we learned from these cities and from China is that the first most important thing which the government has implemented is the social distancing and lockdown. That's the new normal for the time being. And I think we really need to extend that lockdown period, because we are nowhere nearing flattening of the curve, the so-called flattening of the curve, which everybody talks about. That's coming to in the public space, in terms of what should be done from the public point of view. In terms of hospitals, now this is again, we have to be mentally ready, because this is a disease which affects healthcare workers who are in close proximity to patients. So the amount of healthcare worker involvement is up to about 20% in the Western world, where they actually have good PPEs, and some of them may still be lacking in good PPEs, but the incidences are clearly on the rise. So our concern is for healthcare workers, and that's where you and I have to really plan how we accept patients in the hospital. So we need to have an area of triage where there is a fever clinic. That means conventionally, most of the centers have it outside the hospital. It's like a tent. They create a tent. There are doctors who are in full PPEs who actually screen people in terms of the history. Now, in fact, the well-orbed people have come out with the clinical score system, whereby by looking at the clinical score system, you may say, oh, this is a possibility that this patient may have COVID-19. So from that, you triage to a patient. Most of the patients can be treated as an outpatient. As you can see, 80% of patients are sometimes having mild symptoms or asymptomatic. So you need to make certain, reassure people who have cold, cough, and no other major symptoms that they should be isolated at home. And if you strongly suspect, do a test to prove that. So that's the triaging part of how you try and not allow such people to come into the hospital. So the triaging area should be actually a kind of a shamiana outside the hospital area. And from there, you then triage out and see which patient needs to be hospitalized and which patient needs to be in the ICU. So you need to have 3 platforms. One is a COVID ICU in your hospital, which is dedicated to ones who are very critically ill, and those are the ones who would need to be treated there. Second is an isolation ward, where you have a confirmed case of COVID, but is not symptomatic or mildly symptomatic. They can be looked after in the ward, where there are full isolation facilities to all healthcare workers. And then there is a suspect ward, where he comes into the hospital and you suspect that this person has possible COVID. So he goes into the suspect ward. Again, the healthcare workers will have to be with PPEs in this situation. So these are how you classify into 3 categories.
Right.
And,
but Dr. Amin, that brings it to a very important point. The quality control measures so far have been very different. So far, we have been talking about NABH, other various
it is
protocols.
lacking in quite a number of places. And I know of places where they've gone slow. They've started with triaging. Some people have started in the opposite direction. They've created ICUs, but they have not done enough triaging. So I think we need to get all systems into place to really address this issue holistically. So you need to have all flow platforms. That means you need to have a triaging area, you need to have a suspect ward, you need to have an isolation ward, and you need to have a COVID ICU. So this is how it functions.
Right. So all these measures will be required to term a hospital, COVID hospital, where the COVID patients will be taken care of.
Not necessarily. Now, if we got to now consider the new norm is that every patient that comes in as of today, if the community spread has started, every patient that comes in should be considered to be COVID positive till proved otherwise. That would be the new normal if we see what's happening in the cities like New York, and we are not far away from them. It's only a matter of time that we see more and more number of patients, more and more asymptomatic patients coming in, and that's the group which you're really going to get worried about, because when you do testing for these people who are asymptomatic, as you know, the nasal swab has a 60% chance of picking up RT-PCR. So when you have a test which has a large number of lacunae, now if you look at the UK population, they tested 150,000 odd people and only 10, 15,000 are positive. That means telling you what? They're suspected in 150,000 people, but only 15% has got positive. They may have missed a large number of patients. If according to, if you have not done the test properly, if you do say oral swab, the
Gayatri,
pickup
I'm on a
rate is
Zoom
about
call.
30%.
Right.
Whereas
Right.
if you do a
Right.
nasopharyngeal, it's about 60%.
Right, right. So, Dr.
there are-
Dr. Amin, these standards that you just mentioned, I think they sound very comprehensive, and it will be such a wonderful thing to see every hospital following this. Unfortunately, in current scenario where 70% of healthcare is managed at nursing homes, even in city like Bombay, and we have a couple of nursing home owners, we have a couple of medium group hospitals owners with us also, and we have Dr. Avinash Supe, who's running a corporate hospital like Hinduja Hospital. And I suppose that Hinduja Hospital has also had some problems lately. So how do you foresee that the health system will ever come to normal? These nursing homes, for that matter, will have a structural deficit to comply to these norms that you're mentioning about. Dr. Supe, would you like to comment on that? I mean, how do you foresee the healthcare in coming times?
I foresee, like what Dr. Amin said, that every patient now has to be, we have already now started triaging, and we have to develop suspect and other wards. Now, currently, our government system says that all COVID patients have to go to COVID hospitals. But they have to realize that every patient now has to be looked at whether he is likely to be COVID or not COVID. So we have to emphasize on the PPEs, trying to take care at all these levels, and also see that we do these more testing so much that we are able to diagnose them. And every
Can I
hospital.
say something in between?
Yes, please, Dr. Amita. Yes, please, please.
So excellent points by Dr. Amin and Dr. Avinash. And just to add on to it, we had a very interesting study come out from NEJM talking about 1,000+ patients of Wuhan, and only 44% of confirmed COVID had fever at the onset. So it's very, very important that initially 44% only has fever. Remaining 56% do not have fever. So if we are going to say that fever has to be a criteria for us to try them into COVID, then we will be really missing a lot of other patients who are presenting as other systems, because a lot of patients are presenting only with vomiting and diarrhea, and respiratory symptoms and fever are coming 5 to 7 days later. So as Dr. Supe and Dr. Amin correctly said, every patient should be COVID unless proven otherwise.
So based on this point, Dr. Supe and also Dr. Amin, don't you think that every single hospital at some point in time in coming 2 weeks, 3 weeks or 4 weeks would have had a footfall of a COVID positive patient already, be it a asymptomatic carrier, be it a mild symptom guy or a sick guy or a ill guy with some or other knee pain, back pain, or any kind of symptom that may just walk into the clinic and they are asymptomatic carriers and they have already stepped into the hospital, converting it into
Absolutely. This has happened to most of the hospitals in our Mumbai. In fact, this is happening.
Of patients who come for chemotherapy without fever, no symptoms, received chemotherapy, got fever on the 3rd day, and turned out to be COVID. So we have to know that asymptomatic carriers could be walking in every time.
Right. So I think this would surely magnify the concerns of hospital owners. We have Dr. Saraf with us, and we have Dr. Tushar Agarwal with us. Dr. Saraf, would you like to come in? Now, Dr. Saraf from Patna. Dr. Saraf? And we also have Dr. Parag Sancheti. Dr. Parag, let me have your word on that, Dr. Parag. We just spoke about asymptomatic carriers, and within 2 weeks' time, all the hospitals would have already been seeing or already have had a footfall of COVID positive patients, and they should be ideally termed as the COVID hospitals. And even if you have those isolation facilities, you will surely be called like a COVID hospital, and you will have to be managing these patients. What's your take on that, sir?
Yeah, so I completely agree that these asymptomatic patients do exist. The question we should be asking is, how do we identify them? Right now, the kits are very, very less in number, so we cannot really test every suspect. And so these patients who are carriers, who are asymptomatic, are going to be there. My take is that you just kind of have to take the so-called universal precautions and think every patient is positive. Being an orthopedic hospital where I work at, we don't see many such patients. Ours is a pure orthopedic and trauma hospital. And we are not seeing patients with cough, fever, even at this point of time. Some people do come who have had, backaches and knee pain and neck pains, who have such symptoms. Then if we do get the permission, we try and test them. Otherwise, just maintain the universal precautions.
Right. Dr. Supe, before I move on to the other side, can you please tell us now if there are certain hospitals which do not have these facilities of having a separate isolation ward, or they do not have a place for separate ICU for these ill patients? Are they really liable enough to carry out their orthopedic services, or they should strictly say no to all? I mean, what is the medical impact of this as of now?
I think when they are doing in the current situation, when it is spreading so rapidly, this is likely to be taking some risk. So either they should use proper PPE and do it with completely understanding that I'm doing an elective surgery, but that patient can be COVID and it may has risk to all my staff and the hospital. I think if you are ready to take that, that risk may be small, but you will have to take that if you want to do that.
Vishal, can I come in, Gautam?
Yes, please, Dr. Gautam, yes.
So the setup in the United Kingdom is completely different to the way you work in India, and I'm aware of both the work streams. So what we have actually done is all elective surgery has been suspended all across the country, and we realize that there is going to be a repercussion on that going forward. When we actually come out of this crisis, we'll have a bigger backlog of things. But no emergency surgery has been suspended as such. What we have done is we have learned to look at emergencies in a completely different light. And certainly within orthopedics, there is a lot of management that happens conservatively, and we have a collective decision making that happens, which has helped us immensely. Now, in our hospitals, we cannot afford to have a COVID and a non-COVID hospital. So the hospitals are kind of designed into red and green, and in some places across the country, it's red, amber, and green. Amber being where potentially COVID, but not confirmed, they go into an amber zone. Red is positive and green is definitely negative. And they are distributed in that fashion depending upon the bed strength of the hospital, depending upon the patients that they drain and the population that it drains. So in my setup, we have two hospitals, both of which are taking COVID and non-COVID patients. These patients are screened through a screening tool, but I absolutely with Amita and with Praveen that it's not a absolute tool. It's not 100% thing. The statistical figures of the test is that if you can get a good oropharyngeal swab, you may be 65% right. The only way you will be definite, it will be definite that is COVID, if you can get some bronchial washings. Now that bronchial washing is only possible when the patient is intubated, and that's probably quite further down the line.
Yeah, agree.
I think that just to add on there, bronchial lavage in ICU settings, we avoid it as far as possible. We tend to do close collection simply because it's aerosol generating, and we are very, very particular. I mean, if you look at the Italian data, the sampling of any sputum in a tracheal aspirate is a good yield. It is a much better yield than the pharyngeal sample. So
absolutely,
tracheal aspirate is good enough. Bronchial aspiration, bronchial lavage with the bronchoscope is much more aerosol generating, much more harmful to the healthcare workers. And I would, we would refrain from doing it.
Dr. Praveen, that wasn't my point. My point was to highlight that
Dr. Gautam, I'll come back to you. Let me just take this forward. Dr. Praveen and Dr. Amita, I have a question for you. Is it actually necessary to divide hospitals into COVID hospitals versus non-COVID hospitals? Why is it important to divide them? Why can't we just have a generalized thing that every hospital has to behave like a COVID hospital and should take in? Is there a specific requirement for that? And why is it important to differentiate?
Let me tell you how we are functioning at our hospital, at Bombay Hospital. We have 3 buildings in our hospital. So we are now planning to just dedicate one building entirely for the COVID group. So there will be a area which will have a suspect ward in the MRC building. There will be an isolation ward, and the ICU, which has negative circulation, is also the structural changes were done about 1.5 months ago in terms of preparation for air circulation, having 12 air changes per hour. Those are the structural changes which were done in anticipation. We had closed down one ICU 1.5 months ago, and made structural changes. These changes are necessary because this is, as I said, this is the new normal that we are going to be facing. We need to make whatever changes that is possible within the frame of things which allow us to do those changes. And those changes need to be done because this is the new normal. And believe me, if this really goes out of proportion, we are going to have a phenomenal test of our medical services, because that's what's happening in New York, and that's what's happening.
You have to think of a protocol of coming back to
Right. So Dr. Avinash,
COVID is
one
here to stay,
question, how is the overall business getting choked? I mean,
swine flu.
Dr. Amita, quick comment on that, before I go to Dr.
I want to quickly say one thing. This is very important for all orthopedics to know, that basically we require nasopharyngeal and oropharyngeal swab in every patient. So it's not nasopharyngeal or oropharyngeal. It has to be both together, because only then the yield increases. That is number one. And BAL or sputum will only come positive in those patients who have a COVID pneumonia. So you have people of COVID who only have upper respiratory tract involvement without lung involvement, and over here sputum and BAL, tracheal aspirate, everything will be negative. So we have to basically insist that oropharyngeal and nasopharyngeal swab is taken, a good collection. It has to be transported correctly. The viral load has to be good. So this is really very, very important. So the yield improves. And if you are testing and if it comes negative, then do a second sample the next day.
Right. I think. Thank you, Dr. Amita and Dr. Praveen, for bringing this point forward.
Can I add another?
Sure.
See, one needs to be aware that there is a time frame in these patients. There is a stage 1, which is an early infection phase. That's the time when the patient may be mildly symptomatic or asymptomatic. Now, this is the time when the viral shedding is the highest. So the viral is shed for about 4 to 8 days. By about day 10, you have antibodies being produced in your body. So by day 10, you may not get the viral, though you get the RT-PCR, which is positive, which can come positive up to 28 days. So getting a PCR positive doesn't tell you that this patient is infective. If he gets into an ARDS situation, it may be the inflammatory phase. If I can just share you my screen, I can show you what I mean by that. Can I?
So we'll do that, Dr. Praveen. My quick question as a orthopedician, let me just talk on behalf of all the delegates who are listening to you is, say this evening I get an emergency case with a hip fracture or a femur fracture who may probably require surgery, and he is asymptomatic, has got no testing done in past, has got no contact history. What should I be doing as an orthopedician? Should I be sending him to a COVID hospital which has proven COVID cases? Or I should be sending him to a non-COVID hospital like Dr. Tushar Agarwal's hospital, where he himself is scared that if this patient turns out to be positive, my hospital will be bloody locked down by the municipal commissioner guys, which has happened in past to few corporate hospitals, which has happened in Bhilwara, which has happened in Indore, in Bhopal, that a patient who comes out positive and the hospital is locked down. So as an orthopedician, me and as the owner of the hospital, what are the norms and conditions that we should follow in this situation?
Can I answer this? Can I take it?
Even I'd like to answer.
I can.
Yes, let Dr. Amita start. Ladies first, please.
Okay, thank you. So basically, I personally feel that hospitals which are only for COVID, ideally COVID positive patients only should be going there, because non-COVIDs going over there have a chance of picking up infection. Number one. I basically feel that anybody wants to run a nursing home and wants to keep it open during these times have to be basically prepared for everything. So when an unknown patient comes in, they have to have a different triage area whereby there's a different lift, there's a different corridor, and that straight takes you into the OT, and that OT has to be immediately next to the entrance. This patient does not stop anywhere, basically, he doesn't stop at the recovery, he doesn't stop at the anesthetist area. So you have to basically have a separate entry for this kind of a patient in your nursing home if you want to keep it open today and not get blocked. And then basically the thing is that it's very, very important in that isolated area, the patient has to have a mask on his face. If you have the N95 luxury,
I think very pertinent tip. Thank you, Dr. Amita. I'm sure this is one tip that we all must take home from here, is that a patient who's suspect, in fact, every patient is a suspect in the growing times, and every patient whom you're planning to admit has got no symptoms. If he's got symptoms, he's straightforward a COVID patient. You have to actually start thinking of investigating him first and try to send him to a COVID designated hospital, either a government or a corporate hospital. If a patient is asymptomatic,
sorry to interrupt. If the patient is symptomatic, then please see if he really needs surgery, because COVID patients, high mortality, high morbidity. So the
Right.
thing is,
Thank you. Yeah, we are going to come to that. So asymptomatic patient, which is going to be the commonest thing happening to us, asymptomatic patient with an orthopedic problem requiring some kind of intervention, treatment, or consultation. If he's asymptomatic, please try to have these triage facilities in your hospital. If you're not having it, you are probably risking yourself. You are risking your hospital's functioning in future also. Unfortunately, there have been precedents that have happened in Bombay, Bhilwara, Indore, Bhopal, and multiple other cities where patients who were asymptomatic turned out positive, and the hospitals were shut down by the municipal commissioner purely for the reasons of not allowing the virus to separate from there. Dr. Parag Sancheti, your word on that, please.
Yeah, so what has been discussed is right, but at the moment I can tell you what we are doing at Sancheti Hospital, Pune. So the scenario which you spoke about, the patient of shaft femur or a dislocation, so we are just treating them as we would treat any other patient. As long as they are not showing any history of any recent travel, no history of fever, we are checking their temperature, and if all that is normal, then we are not.
With the lockdown, recent travel cannot happen. Lockdown has been present for more than 2 weeks, so we
Yeah, so
can't
understand that.
any longer
So
take travel
before that,
history.
if they have been exposed to those areas, it's just a part of the history, Dr. Amita, we are taking. That is not the only history we take. As a part of the protocol, we have to take all the histories. What you spoke about, having a separate corridor and all those things, as a theoretical, and that's not possible to do that in our hospital also, which is supposedly quite modern. So in other hospitals, we can't do it. So we have to just treat them as positive. And if something does happen, if the patient is symptomatic, if the patient has issues, then I would refer him to a hospital. Otherwise, at Sancheti Hospital, we continue to treat these emergencies, dislocations. What we have done is we have stopped elective procedures completely. It's a complete zero knee replacement, no ACLs, no pediatric work, no spine work. Only emergency work is being done. No elective OPDs also. So
and what precautions are you taking, sir? Like Dr. Praveen Amin and Dr. Amita mentioned, what are the precautions to prevent the spread to your staff? Because ultimately it is all about your precautions, your prevention, your staff prevention for efficient, optimization of your health and prevent yourself for future.
So what we are doing is our staff, we are working at 50%. So 1 week, one particular staff comes, the other week, the other 50% come. We are also, when they come every day morning, there is a temperature check done. The patient, the staff, the doctors and the nurses are asked the history. And of course, we are trying to maintain social distancing in the hospital. Like today morning, we had an important meeting of all the consultants. We saw that, that social distancing was being maintained. So all the regular precautions are being taken. So that is how we are addressing this issue. Only emergency elective work. And there is a chance the collector did call us up. And he said that if the situation does become too much and beyond control, then they will take over our hospital and run it as a COVID hospital. We've already submitted our data. So that is a decision which will come from the government, from the collector office.
I think that's what is
Can I just come in for a second?
At this point, there is an ever-evolving scenario. There are plenty of guidelines, and it is extremely impossible to get all these guidelines in one place because they are so subjective. They are coming from various parts of country, and unfortunately, there are so many guidelines already now. None of them is ambiguous enough to match one with another. Dr. Avinash Supe, I have a very quick question for you. How is we just heard that the staff is working at 50%, however, the pays are going 100%. We heard that all the elective work has gone down, and I assume that more than 60% volume in most hospitals today comes from elective work. So how has the business choked down? What is the financial logistics, the impact on the overall functioning of hospitals that's happening? Dr. Supe.
The revenue has gone to almost 30% now, which is because of the elective surgeries are closed in most of the corporate hospitals. However, your expenses remain same, though they come down to partly, but not fully. So hospitals are definitely going through a very red phase. And that is what we have to really watch over next few months. My one question to the Dr. Amita is that many hospitals are asking for COVID negative test before admitting the semi-elective patients. How good it is and should it be continued?
So honestly speaking, it is complete waste of time and energy.
Yeah.
If the patient is asymptomatic and if you're going to do it, then there is a very high chance that it's going to come negative, even if the patient is positive. So basically the thing is, a sensible thing would be to basically take everybody has proven COVID, just assume
Okay.
they are COVID
And
and take the
spend more
precaution.
money on PPE and all that kind of thing. And the
Exactly.
other care.
You can buy PPEs in the cost of one test. So
Yeah.
Vishal,
Yes.
I just wanted to share something that I am in UK, particularly in my hospital, we have developed a lot of transfer protocols for orthopedic patients who are COVID, suspected COVID or COVID positive. Same thing with maternity patients and surgical patients. It's in a single sheet flow chart, which can be laminated if it suits you. And I'm happy to share that with people if required.
Oh, yes,
So
please on my WhatsApp group. I'll just put it on the group. Thank you, Dr. Gautam, on that. Let me also.
You can share what we have already done here, having been in the thick of it.
Yes. I think this first part of the thing has been so productive. At least now we know what to do with these asymptomatic patients if they land up requiring some kind of orthopedic service, what kind of services are on, the impact on business and the impact on healthcare delivery. May I also call upon Dr. Neelan Shah. Dr. Neelan Shah, you have been the busiest joint replacement surgeon in the city. You've been doing like 150 cases a month. We would like to know the impact for a private consultant like you. What has happened in the, like 3 weeks ago? What were you doing today? What are you doing? And how do you see, because you're like purely into elective surgeries, how do you foresee the future of healthcare now?
Firstly, hello everybody. It's been an interesting discussion. As far as I'm concerned, my practice is completely stopped. I don't see patients, I don't operate. But I think that is a lesser price and we have to get over this. I have a few questions to the people who are making comments so far. One is that the way HIV was there earlier, and we've all done, universal precautions, and we've all operated HIV positive patients and kept ourselves away from it. So the universal precautions that we all need to take. See, we all talk about PPE, but PPE is very different for different people. For some people, it's just a mask. For some people, it is an N95. And for some people, it's the whole thing that we have seen photographs from China from. So what is the current state of PPE in India? Secondly, if, I heard Parag saying that he'll, have people working at 50%. And if some of his staff, God forbid, gets the disease, what is the legal situation? Is the staff going to sue you? Okay, were you forced to, make him work?
Right. Dr. Supe, would you like to take the second question? So tomorrow in your hospital, you have called the patients on 50% basis. And Dr. Parag, you to answer the next. If you are taking up these patients and you are not testing them, you are doing whatever is needed. However, if a patient contracts illness or he develops COVID by a contact history in your hospital, how would you deal with it and how liable are you, Dr. Supe?
Many hospitals in Mumbai, including our hospital, is taking an undertaking from the patient that we are working in this situation and you can do it. Now, I don't know, we are taking that undertaking, but I don't know the legal standing about this because everything is so unclear about it. What is the stand will be taken by the insurance companies? What is the stand which will be taken by the legal and the state? We really don't know. But we are telling them that we are taking all the care. In spite of that, there is a possibility that you may have brought the infection or something like that you are doing. Then we are taking that undertaking from them, that the risk is still there of getting them into complications.
Dr. Parag, if your staff gets infected, so God forbid, if one of your staff develops it and it can be proven that he was in contact with one of the COVID positive patients, how will you deal with it, both professionally, financially, and medico-legally?
Yeah, so first of all, I agree with Dr. Praveen. We have been taking the consents of all the patients, and that's the way to go. If it happens, we don't know what medico-legally impacts it will have, but I can tell you that it will be dealt with sympathetically, because if this is versus not doing it and doing it, so we have to do it and take that risk. As far as the staff is concerned, we have assured them that in case they develop something, then the hospital is responsible, the management is responsible to treat them, and whatever happens in that period while if they are in the hospital, we will deal with it. The problem is, how do you prove that they contracted it in the hospital or they contracted it in the community or they contracted it somewhere else? So it can't be explained, but as a hospital chairman, it would be my responsibility if my staff, gets infected with the COVID virus to treat him and take care of him.
Right. Dr. Meenu Patel is from Melbourne University. He's also from Mumbai. He's been here for quite a while, and I'm sure he knows both sides of the world. And he's from Australia, where things have started getting back to at least to the plateau of the peak. Dr. Meenu, can you please tell us how is the situation in Australia? Have you already started taking up elective surgeries, or you're still in the mode of only emergency surgeries? Dr. Meenu Patel. Dr. Meenu, are you with us?
He was with us some time back. I think we've lost him. It's pretty late in the day. We'll wait for him to come back.
Can I answer a part of Dr. Nalin Shah's question, please? About
Yes,
HIV?
please.
Yeah,
Yes,
so
please.
Dr. Nalin, hi. So you basically asked that, we've been always working in the era of HIV also, but there's a difference between HIV and COVID. So basically COVID is a droplet infection, which HIV is not. So you contract HIV only by handling body fluids, whereas COVID you acquire also by being in the same room. So basically that is the worst part of COVID, why we require so much of PPE. And that's the reason we are talking about putting masks on patients' faces and we using N95. So that is the most important catch about COVID-19, which makes it much worse than HIV actually.
Right.
Also, there's
now,
a lot of discussion regarding the medico-legal aspects, and I think it is clear that we are still not aware because it's a completely new, unprecedented situation. But like Parag very rightly said, the sympathy will be on the side of protecting yourself from COVID rather than missing out on treating a semi-emergent disease.
Right.
Vishal, can I come back for a
Yes,
second?
please, Jimulia. Yes, please.
There was some discussion that COVID test at home prior to admission has no role. But now if you have a neck of femur, who you admit, who is asymptomatic,
What do you want?
what is the role of COVID test on admission and wait 48 hours for surgery? Is there any role of that?
Dr. Praveen Amin, would you like to take that test? Like, should we be operating on these patients who already have an emergent situation, or we should wait for the test to come before we take them up? What is the role of test and the time duration between? Dr. Praveen, your voice.
Yeah. Let me just give you a perspective on this. I think we have to go by what the government is telling us now. The government is telling us we are still in stage 2. We have not yet reached the community stage of community spread. So I guess we need to go by them. But the gut feeling is that the community spread has already begun. That's the feeling, because that's why the question of travel history now goes into the back burner. So clearly we are in a scenario where we will be facing more and more people coming from the community. And be that as it may, we need to understand that 80% of the population may be asymptomatic. So we need to, and also the fact that the tool which we use for testing is not foolproof. So either which way, there have been cases who have been proven COVID, and we have done 3 samples, and at the time of mortality, they turned out to be positive. So we have some limitations, except when the antibody test that comes in, which will probably give us a much more definitive and specific answer. So the sensitivity of the PCR is very high, but the specificity comes down simply because of the faults that can be found with the testing methods and the methodology. So if you ask me that if you have to do it for a particular patient and it comes negative and subsequently comes positive later, that's your bad luck. I mean, I do not have a scientific explanation to say that this patient will not turn out to be positive in the subsequent sample. So again, if you've got an elderly person in an orthopedic group who's got fractured neck or femur, he probably was homebound and has had a fall at home. It's very unlikely that he would be having a COVID positive test. So I think you got to take the scenario into consideration. Somebody who was homebound, fell at home, has never gone out, hasn't had many people coming in, servants coming in and going out. Those are the other people who can bring. If somebody in Dharavi gets it and he is serving the person in that particular area, so he can bring in through the person who's at homebound too. So in many which ways, you could find reasons to believe that the test may be negative in each such scenario.
Right. Thank you, Dr. Amin. We have Dr. Meenu Patel back with us. Dr. Meenu, you are with us. We are being a little optimistic and we want to see and hope and believe that we will be able to follow the path of Australia to contain the virus. Could you please tell us that have you already passed the peak in Australia, and have you already started going on into elective surgeries already?
No. So we haven't passed the peak yet.
we are on the downward trend, so we're flattening the curve. Elective surgery has been completely stopped since the 1st of April. That was our April Fool's Day joke. And the things that have been mentioned, so everyone is to be taken as COVID positive. We have a very, very strict hierarchy of cases. So you got the category ones where they have to be operated upon, like a neck of femurs or long bone fractures, femurs and tibia. And then we have the urgent cat 2s where they may be operated, for example, say a distal biceps avulsion, where it's time critical, but you could investigate them appropriately, where let them have their 2 weeks of quarantine. And if they don't show symptoms, then you assume that they are negative. And then, of course, the cat 3s, which are not to be done till further notice. A very important thing. So I had a tibial fracture in a elderly lady. She was 83. And if we had put her into a cast, she would have had a high risk with her peripheral vascular disease of either losing a limb or losing a life. She was COVID negative, except 15 days after we operated, she became COVID positive. And it clearly shows exactly what we did and why it was important. So we have the strict protocol. The biggest risk is when the patient is getting intubated. And when the patient is being intubated, only the anesthetic staff, i.e. the anesthetist, the anesthetic technician or nurse, and the scrub scout will be in the theater. Everyone is out of the theater. When the patient is brought in, the patient has got a P95 mask or N95 mask, and they are considered as COVID positive unless proven otherwise. We have separate COVID theaters for definitely COVID positive patients. And if somebody was COVID positive and they got a neck of femur, then we would potentially, depending on their age, treat them non-operatively, i.e. essentially make a decision that we're going to let them go. But that is, there's a hospital committee that decides on those sort of soft issues. The COVID theaters that have been designated are within the complex but out of it. So they are completely sealed up. And somebody was talking about air circulations. The one thing you don't want in a COVID theater is positive air pressure. We are so used to laminar airflow and positive pressure. The COVID theater actually has to be a negative pressure theater. So there has been a huge expense to make it into a COVID theater. And same thing with the COVID section of the ICU. Our pediatric ward's been converted into a COVID ICU. And there's a huge expense to make it into a negative pressure so that all the aerosols can be sucked up. So that's a very important thing. Beyond that, you cannot essentially say whether somebody is COVID or not COVID, and therefore medical legally and also ethically, something that is an elective surgery that can wait, you're better off letting them wait. The question will arise, and we are already beginning to have this discussion in Australia. We've successfully flattened out the curve, and what next? Certainly I'm an upper limb surgeon, but I also do trauma, so I've continued to do my trauma work, but elective surgery is dried out. I've had to lay off staff. These are hard decisions that you have to make. In terms of medical legal aspects, if one of your staff gets the COVID and you have taken every possible precaution, then at least ethically, and I'm sure legally, you can't be held responsible for it. So
I think that's a very interesting point, though it is disheartening to know that despite being 6 months with this baby called Corona, despite we hating this much to this baby, despite you being on the flattened side of the curve, after taking all the measures, still the elective surgeries are far from sight. I think we hope, even if we are able to follow the same curve, we are still far away from elective surgeries coming up. And this is one message that we all should take from here, that elective surgeries are far from the thing, and we all must be ready to take care of the emergency surgeries. However, there are certain protocols to be followed. Let me just catch upon Dr. Supe again.
I'll make one point before I go, because it's very late at night. I'm supposed to be having dinner. The police commissioner of our state made a very important point yesterday, and he said that the lockdown is dependent on what is called as a social contract. If the lockdown continues for too long and the people start hurting financially, then you will lose the social contract and people will start revolting. And that will be a very, very difficult situation, certainly in a place like Australia, but certainly in a place like India or in Mumbai, where if the people basically decide, stuff it, we are not going to care, we're going to go back to our routine. And therefore, we have this concept of using the accelerator and the brake, and we've been prepared mentally for it, i.e., you flatten the curve, you let things go, you relax the regulations, you let things happen, you do your elective surgery, you let people go to work. If the cases rise again, you slam on the brakes again. And you may have to continue to do this for 6 to 8 months till a vaccine comes out. Because certainly in Australia, HCQ, azithromycin, everything has been officially banned. You're not allowed to prescribe it because the evidence is just not there. So if anybody believes that these are the things that can be useful, I think that's just a fool's game. And therefore you will have to do your social distancing and the PPE as long as your population will allow you to do it. Once the population says, no, we're not going to do it, then it becomes a problem. And therefore the way to avoid this is to push the brake hard, then let the foot off the brake, let the car accelerate a little bit. If you see there is nothing, then let it go. If you see that there is a problem coming up and you see an upswing, then you have to slam the brakes again. And you may have to do this 3 or 4 times in the next 6 months. Okay, good night, everybody.
Thank you, Meenu. Meenu, we'll like to have you again after your dinner is over. We'll want to see more of Australian perspective of management and what has happened so far in the story from Australia. So we'll see you after your dinner is over. Yes, Dr. Amita.
Yeah, I just want to, excellent point by Dr. Meenu Patel. I want to say that in India, it's difficult sometimes to make overnight and OT, especially for small nursing homes, OT, which is only for COVID patients. So I have basically a solution that the orthopedics can be using it in their nursing homes. So if we have a regular OT, which is not a negative pressure ventilation OT, if it's positive pressure like we have, then what we can do is we can have 25 exchanges per hour. So in a positive pressure OT that we have always, if you have 25 air exchanges per hour, then it is safe. This air should be not going into other hospital vent, it should be going to the outside. But if it is going to the common vent, then please put HEPA filter over there. So that will also prevent the virus from entering the other circulation. So this is something that we could do till we create COVID OTs.
Right. I think very interesting point, and I'm sure we'll all take it from here. Let's move on to another point, preparedness of government and corporate hospitals. Let's call upon Dr. Avinash to be Dr. Avinash and Dr. Rajan. We would like to know from you, how is government, Dr. Rajan Shah, may I have your word on that? How is government and IMA collaborating, and what is the kind of preparedness in terms of policy and strategy making that they are doing to make orthopedic fraternity survive this stress from here? Dr. Rajan. Dr. Rajan, your voice, please. Yeah.
Am I audible?
Yes, now. So
Yes,
we would like to know about policies that the government is coming up, and what do you recommend? What do you foresee from here?
Rajan, this is Ram Chadda. Rajan, firstly,
Yeah,
thank you very much. We appreciate that you are speaking not just as the president of the IMA, but also as an orthopedic surgeon, also as a nursing home owner, also as somebody who runs a nursing college. So with all these things behind you, as an orthopedic trauma surgeon, we want to know the way forward.
The way forward is we will have to start working. If we have to look for our financial health and our mental health. As far as the government's preparation is concerned, when this COVID struck us, the ground reality and the stark truth, bare truth was, we were not at all efficient, self-sufficient in PPE kits and N95 masks. And we had a certain number of PPE kits and N95 masks. And China, 80% of the world was dependent on disposables from China. And this was so well accepted by the WMA president. And he quoted a very beautiful line. This crisis has taught us healthcare is an investment, not a cost-cutting procedure. So taking on the cue, the government went into overdrive and started revved up the army and the industry to make PPE kits. And luckily for us, the DRDO, which has always come to our rescue, came up with PPA kits, tweaking the technology of radiation safety suits, which were already there with international specifications. And I'm happy to share that though its number might not sound great at the moment, but at least 50,000 PPE kits per day are in production at various stages, including DRDO with a vendor, JCT means Pagwada, Trident Towers near Batenda, and 17 units of railways, plus 2-3 more private players. They are all making PPE kits, including 2 jeans factories, which I just came to know yesterday. Now, the automobile industry got into the mode of working on the ventilator technology available. And we should have a ventilator strength of around 50,000 by the end of this month. And as per the government projection, we would achieve a supply of 10 lakh PPE kits per week by the 3rd week of April.
I think that is very encouraging to understand that Mr. PM is working full on toes, and I'm sure with the positive support, not only from government policies, but also from policies through the physicians team and the guidelines, we'll be able to make it a little more secure and safe from here. Dr. Avinash Supe, are you there with us? Dr. Avinash? Dr. Supe?
Yes.
Yeah, we would like to know what level of preparedness is corporate sector doing before I come up to Dr. Amita and Dr. Praveen to recommend us for the orthopedicians, what level of preparedness we need to have. Dr. Supe?
Now, mainly we are trying to have 3 months minimum stock of all the PPE in the most different kind of scenarios, how we are going to keep it ready. At the same time, we are also going into triage areas, suspect areas, and regular areas. We are trying to designate areas where the patients are asymptomatic and those who are suspected, and trying to keep it that way. Also, I think the most important is to develop protocols and train everybody and keep everybody safe. That will probably improve the whole outcome of the whole game.
Right. I think that's something that we all are able to understand, that it's basically the preparedness is concentrating more on PPE, private safety measures. Social distancing is already there. The lockdown is ongoing. It may extend for a while, but the moment we come out of this lockdown, how do we prepare ourselves today in terms of policy making, habit and behavioral changes for the people, for staff, for doctors, so that after the lockdown we are not into a new crisis already. So, Dr. Rajan, do you think there is anything that Yes, Dr.
We have to make the new normal to behave that every patient is COVID and try treating it till the time it really comes down.
Right. Dr. Mihir Bapat, you have something quick comment to make on this. Dr. Mihir Bapat, what is the level of preparedness your hospital has already started on? You also work in one of the corporate hospitals around. What is the level of preparedness that Nanavati Hospital has already started in terms of today, current scenario of emergency cases, and how are they preparing themselves for future? Dr. Mihir Bapat.
I think most of the voice. Can you hear me?
Yes.
So we have been declared as a COVID hospital, and most of the things of triage at the 1st, 2nd, and 3rd level have been already put into place. There's a separate building for isolating patients who are COVID positive. So that takes care of the medical part of it. But as an emergency thing, that means suppose you have a fractured spine with a paraparesis and you need to operate on this. Unfortunately, what the government is saying that even if it's a life-threatening emergency, you have to get a COVID swab first. Now, the problem is getting a COVID swab in the city of Bombay is going to take you 48 hours because there are very few centers who are doing it. So even in life-threatening emergencies, I read on our chat site here that neurosurgeries are also included in this. We had a situation where a subdural hematoma with a deficit was dealing with case.
Right.
We could be taken up. So that's a real issue at the present moment. And secondly is when I had to deal with an emergency, mobilizing my staff, I had to talk to each one of my team members. I cannot force them. I just ask them, are you coming? If they say no, you move on to someone else who's willing to come. So probably that is the best way of taking care of that medical legal part. The second case is the OT. The OT doesn't change. There is no way of getting a gram-negative OT in such a short time. But the real danger is that the patient has to understand. I counsel each and every at present you have been tested negative, but you can turn positive in the next 2 to 3 weeks anytime, and it has nothing to do with the surgery.
Right, Dr. Supe and Dr. Rajan, one quick question also from the delegates coming up, which sounds so logical in these times of emergency. If the lockdown increases, or if we have to really come back to lockdown again after a small piece of relaxation, do you feel that dedicated COVID emergency hospitals versus dedicated non-COVID emergency and elective hospitals made out or separated out will make more difference and bring the health
I think, yeah, what we have to really understand is now we have to divide and stratify our country into different kind of phases of COVID. Now, I think the government made a document. Those where the numbers are very high, there I'm sure we can continue the same lockdown. But where the numbers are not very high, then I think we can categorize them into A, B, C, D. And I think that was a government document that where there are not many cases, there we can allow with the social distancing, even the routine kind of things with lot of care which can be really taken. But those
Right.
where there are very high incidences, there we may need to continue the current strategy. And over a period of time, we start releasing it and do that kind of an affair.
Right, Dr. Rajan, your word on having recommendations from IMA to government to make some hospitals or new addition of only COVID dedicated elective oblique emergency hospitals.
That is already there.
Yeah, but I think it's still like a mixed bag where COVID, non-COVID both are there.
No. Wherever, rather at the moment with the current projections, they have taken up more bed strength. And the railway hospitals, the hospital on wheels, it singularly has a bed strength of 25,000 beds. So they have very clearly said, you are not, even in our district, there is a COVID hospital in ESI hospital. They say you receive the patient. If he needs any other ventilatory support, they have taken up the medical colleges one wing totally for dedicated critical care of these such patients. So these
Right.
guidelines are there all across the country.
Right.
It is
Okay.
not that, yes, some
That's
variation might be
really
there.
that's really warming
Maharashtra,
and
all the
that's really
municipal
warming.
hospitals. They
Yes.
are first saying private sector we will leave the last.
Right. That's
That
really
is
warming
us.
and wishful to understand that we already have dedicated COVID hospitals where these problems can be tackled more efficiently because the manpower is more efficient there. Dr. Amita and Dr. Praveen, let me just put you through this. Like we as normal orthopedicians, how should we and individually be prepared, and what is the level of preparedness that we should show or we should do to make ourselves future ready in terms of COVID? COVID is not going to get away soon. So what is the level of preparedness we should keep in ourselves as individuals?
Well, there are three things. There are three levels of protection that we need to take care of. And if you are aware, I had sent you images of different types of PPEs for different categories of people.
Yes.
Every person doesn't need to wear an N95 mask. This is a myth. N95 mask is to be worn by people who are more prone to subjected to aerosol generating this thing. And the face shield, the high degree of protection is for patients, the anesthetists, the intensive care people. The N95 mask, I see people walking in the streets with N95 masks. That's a waste of N95 mask. Clearly, you don't need that kind of wearing of mask. So I have sent you an image of the three categories. You must realize that the 3 points of entry of the virus are through your eyes, through your nostril, and through your mouth. These are the only point of entry where the virus enters into your body. No other area can a virus enter into your body. And remember that a good soap and water hand washing is far superior than your quick wash with an alcohol. If you do not wash, the 20-second wash which the WHO recommend, that is one of the biggest downfalls of how or one of the biggest reasons why the virus spreads. So as I said, there are 5 points of entry: the 2 eyes, the 2 nostrils, and from the mouth. So you need to protect these areas. Avoid handling, you as healthcare workers, if you want to touch your hand and mouth and eyes and nostrils, please wash your hands before you do that.
These are the simple norms you need to tell your patients, you need to tell your relatives, you need to tell everybody about the basic fact about what coronavirus is. The coronavirus is here to say. It's probably, there is a lot of talk about saying, oh, it won't come to India, the temperature here is high. Now we've seen it come to India. We've seen a second surge in places like Singapore, where the temperature is more higher than what it is now in the month of March and April in this thing. So temperature may reduce the spread, but it does not restrict the spread completely. It may reduce the degree of spread, but the spread still takes place to a lesser degree of extent.
So one is to reduce physical contact, and second is to keep yourself safe in various forms. There are standards of
social
PPE
distancing,
that one should follow.
the social distancing of so-called 6 feet is when somebody is breathing normally. If somebody is coughing, you need to keep a distance of 12 feet because the micro droplet that can spread is high. So you wear a mask, a regular cloth mask. If somebody wears it in the street, he prevents it from others from getting it. So he may not get the infection, he may not be prevented from getting the infection himself, but that droplet infection is restricted. And if you can share on the screen the 3 protective layers that I shared with you in the Bombay Hospital group, the categories. Yes. See, imagine if you are in an aerosol area, it's important to wear goggles. It's important to wear N95 mask. So those are the things you need to share with people, is what is the kind of care you need to have. Where you need full PPEs, where you need a plastic gown, just a plastic gown, and goggles and this thing. So these are the things.
I think very important, and I'm going to share this to the whole group around here. Dr. Amita, quick comments, how to make us, we already heard Dr.
Vishal, on this topic, hi, this is Samir. Vishal, I have a question to Praveen and the people at this point. Please. I think the surgery and all is fine, but of course, maybe this may be a step, but even simple seeing patients, like maybe in a clinic, I know we are not doing it now, but at some stage when we have to do it, what is the level of PPE? Because I understand that infection into us is definitely going to go through these orifices, which you said, the mouth, the eyes, and the nose. But there is also a concern that you would be carrying virus particles on you when you go to your own house, etc. So, you know,
I think the lessons we learned from, can I answer this question?
Why we don't want to answer this question here is because this is like we have a part 2 coming up on 16th, which is on Thursday, where we are going to speak about life with Corona, but after lockdown. Our OPDs will start. We don't want to promote OPDs at this point. The message is that through this webinar, even if we tell you,
I'll wait for the answer next time.
I'll give you a small answer to that. You know, you need to know one thing is you got to go by the SARS model, where people in Hong Kong and Singapore learned about the disease, and this coronavirus is just another form of the coronavirus which caused SARS in 2003. Now, what they learned in that is that the time that you can possibly get infected is if you are exposed to somebody for more than 15 minutes at a distance of less than 6 feet. Then if somebody is positive, if he is not having symptoms, not coughing, that is the exposure time that you need to be having a risk of getting the infection. So a minimum of 15 minutes, that's what the Hong Kong, Singapore model said. The Hong Kong model said 30 minutes. So I think, you know, I would push on to 15 minutes rather than 30 minutes. If you are exposed to somebody for less than 15 minutes, for less than 6 feet distance with no PPE protection, then you are not at risk. If it is more than 15 minutes, you are at risk.
Right. I think point is very well, Dr. Amita. Dr. Amita, the level of preparedness the orthopedician should have. We have already spoke about social distancing. We spoke about following lockdown very, very stringently. We spoke about least possible contact and keep a safe distance from these patients. We also spoke about the role and importance of different levels and different types of PPE. What else do you feel that in these times where lockdown is working, how can we resume our service?
Okay, washing hands is very, very important in between patients. If as far as possible, don't touch anything. You know, basically it could be a simple thing like just avoid touching patient's prescription paper as far as possible. I would like to give you, extending on this for orthopedicians who may need to operate in this situation, a few tips over there. So basically the thing is the patient has to be wearing a mask. Okay, that is really important because he also has to prevent spread of infection to others. So basically the thing is that the patient has to be wearing a mask, which is very, very important, number one. The second part is that the way from the patient's room to the OT should be minimum. The OT given to this patient should be the first OT in the OT area so that he doesn't move around too much. All the patient's reports should be kept outside the OT. They all should be seen outside the OT. Till the patient goes in and intubation is going to be started, he will be with a mask. During intubation, only anesthetist will be inside, and if possible, we keep the plastic acrylic box to prevent risk to anesthetist. After intubation, wait for 15 minutes. The surgeon should come in only 15 minutes after intubation is over. And then basically before the surgery starts, the matron has to prepare a trolley. Every possible instrument has to be present over there, and only instrument that is required should be over there. During the surgery, nobody should be going out to get the surgery. Nobody moves in and out of the OT, even for a COVID suspect or an asymptomatic carrier you are operating upon. And also OT notes are not to be written inside the OT. All the files will be outside. After the surgery is over, then only write things. So basically this is also to prevent transmission of infection to fomites. And these things are very, very important.
Hello.
Also, the surgical time should be the least possible. We avoid situations whereby we have to use suction, because these also give rise to aerosol, and aerosol is a risk, you know. So even applying pottery is aerosol producing, applying suction is aerosol producing. So keep your surgery to minimum possible time, small incision, and really a very clean surgery so that chance of bleeding reduces, because actually controlling bleeding is also aerosol producing.
Right. I think this is something that is very, very important. We all take in messages from here. Dr. Abhay, before we move on, I think I'm told that Dr. Rajan Sharma, the president IMA, he's got another meeting to schedule. I'll take this opportunity to thank Dr. Rajan. Dr. Rajan, thank you so much for being with us.
Thank
and
you.
I'm sure you're going to take this voice ahead to the government officials and would like to surely make this world a safer place with all the efforts that you're going to put in from here on.
You can
Thank
share the
Dr.
details with me.
Yes, I will. Thank you so much, sir.
Thank
Dr.
you.
Abhay,
Thank
Dr. Abhay and Dr. Milen are two guys who have also taken forward the preparedness from here. They have also done teleconsulting and video conferencing. Dr. Abhay, would you like to please bring in highlight, because that's something that is the future. We have to continue consulting, reduce physical contact. So Dr. Abhay, how have you been running this teleconsulting and video conferencing? And then we'll also hear Dr. Nilen Shah's version on it.
Basically, just because COVID is there, normal patients are not there. They're also there and they need to be tended to. I think you all agree that you've been coming out of practices of 30-40 patients a day, and now suddenly 0 patients a day. So there is a demand, and to meet that demand, you have to have some kind of a supply. So you got to think ahead. It's a bit uncomfortable to examine a patient on a video conference, but you got to think ahead, think out of the box, think futuristic, because this thing is not a short term, it's a long term. And hence this video consultation has to start not tomorrow, but yesterday. The sooner you get into it, the faster you're going to be on the run, and you're going to be, in the process, and that's going to make your patients happy. That's going to stop unnecessary visits to hospitals by you and your patients.
Right, Dr. Nilen, how has your experience been so far, and how do you manage? What is the satisfaction quotient of these patients who are on teleconsult?
Well, I just started this morning. I had some 3-4 patients do a video consultation with me this morning. Realizing the same fact that we don't know how long this is going to last, and rather than attending calls all the time throughout the day, it is better that you designate a certain amount of time that this is what you would be doing. The other thing that I feel
Vishal,
yeah,
can I come
Gautam,
in on
we'll come
this?
back to you. Yes, Dr. Gautam, I'll get back to you. Let Dr. Nilen finish. Yeah.
So what is important is that this is a disaster for almost all of us. But we need to look at it also as an opportunity for us to proceed higher, that we may be short of time for doing a lot of things. Like I did another course on research education online. Secondly, spending time with your family, which we normally don't have. All these things are there. So we need to balance it and look after our patients as well. So having designated times for these video consultations, I think is very good. So I have currently given an hour in the morning, an hour in the evening, for the patients to do video consulting.
I think this is a wonderful concept. Yes, Dr. Gautam, your word on that.
So basically, we've been doing this for the last 3-4 weeks, and I'll give you a heads up on how it's been going on. So although our elective clinics have reduced, they have not been cancelled. All the patients who are there in the system are still getting followed up. So my secretary rings up these patients that there is going to be a phone call coming from the consultant or a member of his team. I then have a one-to-one consultation with the patient. We have to go through the normal information governance checks of identifying that the person on the other side is the right person and that kind of thing. And the patient satisfaction actually is extremely good because we have an electronic patient record system in our setup, so we can do everything, and then I can sign off with a arrangement for a further follow-up as well, perhaps in 6 months' time for a joint replacement that is required. If they are willing to come in to have an X-ray done, they can come in and have their X-ray done in our hospital. I then tell them that you can ring my secretary, I will look up your X-ray online, and I will come back to you.
Thank you, Dr. Gautam. I think it's a wonderful thing, and we all must start it. If we have all not started so far, let's all get.
Just one more thing, Vishal, is we do our fracture clinics also in the same way. We do something called the virtual fracture clinic to basically minimize patient attendance. So patients who come to A&E are put on the virtual fracture clinic with the appropriate notes. We then go through the notes, decide on the treatment, and if it's a patient who just needs to come back to have their plaster removed, we put them into soft cast so that the patient can just cut it off on their own and start mobilizing. And they are then referred to a library of physiotherapy sheets where they can pick up the appropriate thing and start doing their own exercises.
Yeah, thank you, Dr. Gautam. Yes, Gautam, I think I'll just sum it up here. So far, we are an hour into this session and we have discussed some of the most important aspects. COVID is here to stay. The lockdown is on. It is going to remain on. As of now, everybody is of the consensus, no elective surgeries, no OPDs. And even when the OPDs start, the basic principles of social distancing have to be followed. You have to take care of yourself. You have to make efficient resource utilization. You have to ensure that your safety is the primum. At the same time, emergency surgeries have to continue. For the future, be future ready. Telemedicine and video conferencing is the way to go ahead. Try to start getting on the board, otherwise you'll be left behind. And now we are in a situation where we are planning to do emergency surgeries, and the way they have to be evaluated, basically some primum, Dr. Praveen Amin and Dr. Amita have just mentioned to us. The policies are on the way. The government is very, very pro on it. And now we have a case where a case of this type comes to you and has got a fractured neck femur. You get a call and patient is in the casualty. What do we do now? Should we, this patient who's got no COVID symptoms, no signs of any fever or cough, should we just directly take the patient into OT and follow the same guidelines?
Basically, Dr. Praveen, I mean, I'll come in here and we are going to pin you down as a consultant who has to give us fitness to do this case. What is the bare minimum that you're going to do to let us do this surgery? Because it's a fairly emergent surgery, but it's not emergency as in middle of the night. So how much time are you going to give us, and what investigation is the bare minimum that you do to clear this patient for surgery?
Before Dr. Praveen comes in, Dr. Praveen, while you are doing this, I'll just like to mention for the sake of all delegates, these are all guidelines that are being given by the specialists here. They are not any written recommendations or evidence here. These are the guidelines by the specialists mentioned here. And after these guidelines, they come up, we are going to have a word by people who are already into it. We are going to have a word by Dr. Praveen Amin, Dr. Amita Nene. We have the anesthetist, Dr. Bala and Dr. Kumar Velam with us. And then we are going to hear the NHS experience on how they are managing their patients who are COVID positive versus COVID negative. Over to you, Dr. Praveen, with a question there.
Yeah. Abhay, the question that I would like to answer is, once the lockdown comes off the picture, where you would be then planning this thing, and hopefully by that time our rapid diagnostic test would have come into the picture, whereby the BioFire system and the XLAMP system, which gives you a result in 45 minutes. So if that the BioFire system is now available in major hospitals, you go to Bombay Hospital, Hinduja, all the major hospitals have the BioFire system. Once you get the screening tool with the BioFire system, you would get a result within 45 minutes.
Doctor, I mean, this patient has come right now to casualty, and I need you to clear him for me to do surgery tomorrow.
Correct. That's what I'm trying to tell you, is that if I have a rapid diagnostic test, and if I know that now that there's a community. Now, for example, what are we concerned about? There are areas of lockdowns in the city where they're concentrating more lockdowns. Like there are certain buildings where there have been people positive completely, those buildings, nobody is allowed to move out of the building. So you get data from the municipality to find out, is your patient coming from that area, which is high risk area? Those patients are at a higher risk of having COVID positive, because it tends to spread in the community very fast. Once it has seen in the way we are seeing reports out of New York and all that, I won't be surprised if we find these numbers escalating in large numbers. So I think we need to keep the information available from the municipal council that which areas are the real hotspots. If your patients come from that area, consider him to be COVID positive. Now, for example, southern part of Bombay has hardly any cases. And now you've had some 6 cases in the Taj. So if you go to Kulaba area, they still haven't had cases there. So identify those areas and see if this patient is coming from there, less likely to have it. But again, the new norm is consider every patient to be COVID positive.
The question is, will you do a swab? And if you do a swab, will you wait for the report to come out to give us a clearance? And if the report is negative, will you say, clear, this guy is safe?
My answer to that question is, how urgent is your surgery? If your surgery is life-threatening, that he needs to be operated tonight, I would use all the PPEs that is needed for everybody in the OT. He moves to an ICU which has got facilities to look after COVID patients. So go into a suspect ICU, which is probably a single, we have hospitals which have, negative pressure ICUs in the city of Bombay now. So identify those places and keep it in that ICU.
So in that situation, do you think that all surgeons should also get a swab done for themselves? Because there's equal risk of a surgeon who's a high-risk health professional transferring his COVID to his non-COVID patient. Do you think all of us should get swabs for ourselves?
How often you will
It's never ending. It's never ending.
How often
you can't. How often are you going to keep doing the swab? It's not like it's a dynamic thing. Like today you have done your swab. 5 days later you are exposed to somebody who has it. Will you do your swab every week? That's my question. I don't think it's practical. I don't think it's practical.
So no swabs for surgeons.
You have to look at
if you are
symptomatic. You should get a swab done.
Vishal, can I come in on this?
Yes, please.
Yeah, see, we are talking a lot of theory. I will tell you my practical experience. My elective surgery is 0. My elective OPD is 0. I'm only doing trauma. We are showing an X-ray of fracture neck of femur. I go to half a dozen hospitals. Everyone has a changing dynamic policy at the moment. Every day rules change. Now I've done one hospital neck of femur with full PPE in the OT. Okay. Even though the swab was taken, we did not wait for the swab results for 48 hours. We operated at 24 hours with fitness. 48 hours later, patient was discharged. Now I have another patient coming to another hospital currently, has had a swab at home, is doing all the pre-op results at home, and will be admitted only when the 48-hour swab result is clear. So for people like me, we go to different setups, we have different rules, and we follow different policies, and these change every 2 days. So to say, we wait for the rapid test and all, we cannot wait. Just now we have a patient currently with fracture neck of femur. What we are going to do?
Okay, can I just say a few things over here?
Yes, please.
First of all, I want to clarify one thing, that the swab test is available. The results are available in 24 hours flat everywhere. It doesn't take 48 hours. The test takes only 4 hours, and every lab is doing at least 2 batches. So basically, please identify. No, just a minute. Let me just go on. No.
The result we were told will not come for at least.
Result will not come before for 24 hours to 48 hours. Amita, let's be practical. Today, when we send a swab to a X lab, you don't get it before 24 to 48 hours. That's the fact.
Dr. Amin, I have sent at least 20 swabs. I've got all the results in 24 hours because you communicate with the doctor over there and the result comes to you within 24 hours. It's very, very important to communicate, have a point of contact. We have only 6 labs which are doing it. So it's extremely easy to establish point of contact, which I can help everybody with. So it's very, very important.
I think, yeah, for the point of orthopedicians, now we have this case, we have done a swab, we are considering this as a positive.
I was just coming to that, Vishal. I was just coming to that. I was just interrupted by people. So I'm talking about what is practical and what is required. So basically, the thing is, if surgery is life-threatening, you need to operate immediately. Please operate immediately. I mean, the thing is, if the patient is asymptomatic, then you anyways have to take all the proper precautions. Just go ahead. If you have 6 hours, if you have 12 hours, you basically, the thing is, then it becomes little medical legal. You talk to the patient that we will send a swab. If you may be asymptomatic carrier, if the swab comes negative, you may be still positive. But if the swab comes positive, then the chance of you having a complication because of the surgery increases really a lot. And therefore, then you reconsider your decision of surgery again. So according to me, every fracture neck femur is never important, requiring surgery within 12 hours. So the thing is that again, as I'm saying that my reports I've also got in 12 hours. So the thing is that I give the swab in the evening. I've got the report very next day by 1 p.m. because I'm communicating with the person who's in charge. So the thing is that, and you also need to understand elderly patient who has comorbidities, like it was shown, obese people, blood pressure, diabetes, fracture neck fever. Anyways, there are more high chances of mortality. So if the patient was an asymptomatic carrier and dies because of COVID, then what? So these things are very, very important, you know. So the thing is that if you have time for surgery, then you can discuss with the patient. If there's no time for surgery, then no need to wait for the swab, operate as if it's a COVID positive patient.
Right. Just taking this forward, Abhay, one question. Now, since in this scenario, if we are talking about a situation where every patient has to be considered a COVID positive, does that mean that all these patients in smaller nursing homes should not be managed?
Because exactly the problem is at the level of policy making. If a hospital has a COVID positive patient, the entire hospital is being shut down, and that's, I think, a very skewed policy, and we need to thrash our heads about this and
Abhay, I'm sorry to just, sorry. So basically, your hospital gets sealed off if proper precautions were not taken. So basically, again, I want to insist that the nursing homes who want to continue operating and want to remain open, please identify an area which is separate from where normal people move around. Every person who's going to handle the patient, make sure they're wearing PPE. So whether it's a ward boy, whether it's a nurse, whether it's an anesthetist or your resident or your doctor. So people who have come in contact with these patients, and if they are wearing PPE, and if the patient turns out to be COVID positive, and you've taken precautions, your nursing home will never seal down. That is what is really important. That is what I'm trying to press upon, that we want to move ahead. We want to learn how to make our nursing home COVID patient friendly if it's an asymptomatic carrier. So
this is important. This is very important, not today, but for the future when the lockdown is over. Every single orthopedician, every single clinic, every single nursing home will have to start practicing this if they really want to continue delivering services in the future. I think this is one point that we all must carry home from here. Dr. Amita, thank you so much. Yeah. It's very pertinent, I think.
Lockdown is over. Even like from tomorrow, we can just, nobody is like having so many patients that they don't have time to plan. So according to me, start planning from now, even before the lockdown is over, that if you want to work, even if you want to operate a week later, like how Bombay Hospital gave time to make our ICU into negative pressure ICU, we stopped the ACs, etc. You can work upon it, work upon OTs, which will have, these 25 air exchanges per hour. Please put in HEPA filters. It's all possible. It's very easy. Sit with somebody who understands, sit with an engineer, and everything is possible.
This might be a good time to get in the next set of physicians who are in the line of fire, sides of Dr. Amin and Dr. Amita, who are the frontline warriors, the anesthetists. According to most, they are the next most affected set of physicians. And Dr. Bala and Dr. Veerappan, if we can have you on stage and tell us what are the changes that have happened between the time that a patient gets into a hospital to the time he's rolled onto your theater, and then what happens, what are the new things that you're doing during the intubation and the extubation time, and what other things do you do when the patient gets out to the recovery? Dr. Bala, can you have a go at this, please?
Yes. Thank you, Dr. Abhay, and thank you, Vishal and Dr. Ram. Actually, being a part of Ganga Hospital, this is being a tertiary care trauma center, we keep getting cases. On an average, we get at least 15 to 20 trauma even today. And as discussed, we consider everyone as a possible carrier. And what we have done, the changes that we have made, it starts from all the healthcare worker, right from the security to the doctors. Everybody have been educated about the way the disease is transmitted, and droplets, direct contact, and fomites. So this has been told to everyone, and we have established a protocol of cleaning even the doorknobs and what has to be done, who has to clean it, wearing a glove, right from the security onwards. And the temperature monitoring is done on arrival for everyone, including the patient and the attendant. And anybody having a temperature is not allowed inside the hospital. That's number one. Number two, if the patient has a temperature, immediately this patient is informed to the HICC and the concerned admitting unit consultant, who comes in and decides whether we need to allow this case inside the hospital or not. And when they enter into the emergency room or the casualty, everyone in the casualty, right from the lowermost stretcher boy until the doctor there, everybody has got, they use only a face mask now, but all of them have got a face shield, which is a simple one, which is made by the local LG equipment. It's a jugaad actually. It's just 55 rupees on every day. The minute they come, they wear this face shield, and all of them wear a glove. And every patient coming inside and the attenders, everyone uses a sanitizer before they're allowed into the casualty. And again, a temperature check is made in the casualty when they come in. And now the next, whether this fracture needs to be operated or it can wait. If it can wait, they are managed conservatively and sent back home. And if it needs a surgery, the things that we have done is, it's not a protocol to send swabs for all these cases. So what we do is we plan the procedure. Majority of them, we try to do it under regional block. And all the patients who enter, right from the time they entered up to the operating room, whenever they come outside the rooms, they come with a face mask. And now what we have done is, since the elective surgeries are not there, all the general wards or common sharing rooms are closed. So every patient gets a single room, and all of them, the minute they come out of the room, the attendant and the patient wears a mask. So when they come into the preoperative room, the next check is done. And all these patients who come inside the OR, when we do the block in the block room, it's only the anesthetist and one assistant who is present there, and nobody is present. And they wear the face mask. And as I said, it's done under ultrasound guided regional block. And we made sure that all the equipment that is used are neatly covered, and we dispose of the tegaderms that we put in, so that we make sure there is no fomite contact. The fomites don't transmit, especially the transducers that we use. And what we have done is, when we use a general anesthetic in this patient, we have again designed our own acrylic negative chamber container. This is something which is very good. I can share it with Ramchandra sir and Abhainane. So this is made of acrylic, and we have made 3 different sizes based on whether the patient is obese or whether it is short statured. It covers on the head on all the sides. So it's on the intubating end of the patient. So we have 2 holes which the anesthesiologist inserts inside. The anesthesiologist, basically every case that we do now, they have the N95 mask, and they have the additional face mask with the shield, and they have a goggle, and they have the gloves, and they use this intubating acrylic negative chamber shield. So both the hands goes into the negative chamber shield, and there is a negative suction which is applied to it. So constantly, instead of the theta being negative, all the aerosols will be sucked into the suction apparatus. And what we have done is, for every general anesthesia, we use 3 HMEs, one at the proximal end of the endotracheal tube, and the other 2 when it is where it is connecting the anesthesia machine, both the inspiratory and the expiratory port. And by this means, you are preventing any of the droplets by entering into the anesthesia machine. So this has been and during intubation and extubation, we use this chamber to make sure there is no aerosol spread. And the most important thing is, when the surgery gets over, because we have more cases, we have closed 5 theaters. The elective theaters we have closed, only 5 trauma theaters we open. And most important thing is, how do you manage this theater when the case gets over? So after every case, we switch on the substances which are used is either 2 to 3% hydrogen peroxide, complete fumigation of the operating room, and all the contacts, surface contacts, are done with bacillol wipes, which is an alcohol wipe, and you turn on your UV light and give a contact time of minimum 20 minutes before you take this next case inside. So, and the patient goes again into an isolation area where there is the patient is nursed by one single nurse, and all of them are there in protective gears, basically with an N95 mask, not a respirator, but the lower grade N95 mask, not the PP2, but PP1 is there for all the post-op and HDU nurses. And we closely monitor them for any rise in temperature in the post-op to see whether any of them have developed symptoms later. So this has been our protocol, and on an average, we have been operating roughly about 15 trauma every day. And these small measures which we have taken have helped us to make sure that none of the healthcare workers, so we have been doing it for the last 3 weeks, none of the healthcare workers have developed any symptoms, nor our patients. Thank you so much.
Lovely, Dr. Bala. That was quite exhaustive. Dr. Veerapan, can you come in here, because you told us about the changes you made in the OR, and there seems to be some contradiction coming from Dr. Chakravarti, who says that negative pressure is not really needed, and you can do this with laminar airflow changes. Dr. Veerapan?
Dr. Kumarvel Veerapan, I think he's just reconnecting again. Meanwhile, can we also have a word about prophylaxis for healthcare workers, both from the anesthetist point of view and orthopedic surgeon's point of view, and primary contact of patient? Dr. Praveen Amin, while Dr. Kumar comes in, can you please tell us about the role of prophylaxis in these healthcare workers? Sir,
you're mute, Dr. Amin. You're mute. Can you unmute yourself?
I have unmuted myself. Abhay and Vishal, really, if you ask me for data existing for prophylaxis, there is no data existing. What has been recommended is by the ICMR to take chloroquine as this thing. The purpose, theoretically, there is some role for chloroquine, because over the years, if you see, publications right from the 80s, there has been a method by which chloroquine increases the acidity of lysosomes and prevents the entry of viruses into the cell. So that's a theoretical approach of reducing the entry of the virus into the cell. If you ask for literature to support this, there is none. So we just have to go, because the ICMR has recommended it. If somebody of your healthcare worker gets it and you have not provided, whether there's a medical legal implications to it or not, I'm not aware of it.
Have you taken it, Praveen? Have you taken it?
No,
HCQ?
No.
Dr. Abhay, actually, in our hospital, since we are operating every day, all the frontline healthcare workers, we have taken 400 milligram of chloroquine every week for the last 3 weeks.
Yes, exactly. The recommendation came in. I'm a respiratory physician. So the thing is that I still deal with respiratory patients during emergencies. I started it on the very same day. And I'm quite convinced about it, that any added protection, even 0.01% in addition to PPE, if I can get, I want to get it.
So what is the recommendation for all the orthopods who are going to come across these kind of patients in future?
So Vishal, honestly speaking, the recommendation is only for currently 2 categories. One is the doctors who are looking after possible COVID or proven COVID patients. So we respiratory physicians would be taking every respiratory patient as a COVID. And the second thing is that asymptomatic contacts of proven COVIDs who are staying in the same household. So the thing is that the dose is 400 BD, and then once a week for 7 weeks for doctors looking after COVID, and the home contacts, it's for 3 weeks. You take 400 BD and then 400 OD for 3 weeks.
Right, thank you. Dr. Veerapan, you're back in the fray. Can you please tell us about the OT conditions?
Dr. Abhay, before Dr. Veerapan comes in, one quick second. Dr. Avinash Supe, our chief panelist today, he's about to leave. I would, from on behalf of Bombay Spine Society and all the panelists, I would like to thank Dr. Avinash Supe for coming in and contributing some valuable inputs. We are really thank you, sirs, that you came in and helped us to understand not only the government preparedness, the corporate level preparedness, and also about the plans that we all should be following from in here. Thank you, Dr. Supe. We will see you again on Thursday and Saturday again for this part 2 and part 3 of this. Thank you, Dr. Veerapan.
Can I just make a comment?
Dr. Vishal, can I leave this because I have another webinar at 6?
Yes. Thank you, Dr. Venkat. Thank you so much.
Thank you so
Praveen,
much.
Vishal, I need to make one more comment.
Yes.
The comment I need to make is, this is data coming out of the Rheumatology Society of the US, American Rheumatology Society. What they have done is they've looked at their data of patients who are on regular doses of HCQ once a week. And they have found 25% of their patients have turned out to be COVID positive. So these were people who were on HCQ. 25% of these patients were registry.
Immunosuppression, like steroids.
Hello. Can I finish, please? The HCQ, which was given to patients with rheumatoid arthritis and patients who have been in remission and taking HCQ, 25% of them turned out to be COVID positive in US. That's what I like to say.
Right. So before
there's a lot of controversy on this.
before we move ahead, Dr. Bala, he has another webinar to attend. Thank you so much, Dr. Bala, for coming in and giving us the anesthesia considerations. We all must summarize this and understand this, that the complication rate of anesthesia in COVID positive patient is very high. The mortality rate ranges from 19 to 30% depending on the comorbidities of the patient. And you surely don't want to have any of your elective COVID-19 positive patient to develop any kind of mortality, even if it is 1%. So please try to be very, very sure if you really want to operate upon these patients who are COVID positive. And in absence of COVID being positive, please try to understand that despite the best care, you still stand a chance of spreading it out. And the protocols of anesthesia, the OT movement of the patient inside, and also the doctors and also the staff have to take a certain level of precaution before you really venture into this. And these protocols, we will keep evolving with time. Okay, Dr. Kumar Velandia, please. Dr. Abhay?
Yeah, I can hear you all. Can you hear me? Can you
Yes,
hear
sir.
me?
Yes.
Thank you. Thanks for inviting me for this webinar here. Very interesting set of talks from loads and loads of learned colleagues of mine in India and world over. Few things I wanted to say here is that we've been in this COVID damn thing for the last now about 2 weeks, 3 weeks. We have about, at the moment, today morning, we had about 22 patients in my ITU and theaters, which are like the ITU has been expanded into theaters. One thing I would like to say to my friends is that, and I personally have intubated about 5-6 patients of active COVID and I've transferred them into ITU. One thing I would like to say to my colleagues is the situation is very, very, very scary. These patients whom, well, but you can say my opinion is quite biased because I'm seeing the other end of the spectrum where the patients are being referred to us to be transferred to ITU. But these patients are really, really sick. I've not seen this kind of a sick patients, such sick patients, and in such variety of patients in terms of age, BMI, comorbidities, and so on and so forth. The situation is really, really scary. Now, there's loads and loads of talk been, I don't want to kind of carry on with this patients whom I'm seeing at the moment in ITU, because this webinar is about orthopedics and how anesthetics will vary. So I'll move away to that now. There's a loads and loads of talk about PPE has been talked about. But one thing I would like to say about the PPE is here. One is to have an appropriate kind of PPE. And it's not easy to work wearing all the PPE in theaters. It slows our speed down. The communication it's totally at a different level because all your face is covered, your mouth is covered, and you are echoing within your own helmet. Depending on echoing within your helmet, it's very difficult. You can't even lip read because the masks are covering your faces. So it's a big challenge. And again, coming back to that time, we spoke about the air conditioning in theaters and all, wearing all the PPE. And if you're working in orthopedics, wearing the lead apron, you are sweating. You are sweating. Even your undergarments are getting drenched in your own sweat. This is when I'm talking of is when your air conditioning is full blast on in theaters. Again, getting into the controversies about this discussion about negative pressure air conditioning and positive pressure air conditioning and the air movements and so on and so forth. We looked into all these possibilities in my hospital. Me and BJ, Mr. BJ Singh, we both work in the same hospital. We looked into all those possibilities. It's not easy to convert the air conditioning from positive or the laminar flows, what we have, to negatives. And in this time of lockdown, to get the workers into the hospital to do it, A, it's not easy, and 2, it's bloody expensive. We guys, all over the world, we never ever thought in our lifetime that we will be facing this kind of a situation. So loads and loads of things have to go into all those things. And in an ideal world, yes, you can have a isolated corridor and so on and so forth. But this kind of resources what we have, at least thank God in UK we have an NHS which foots all the bill. And money is not a criteria for us. Money is being sent we are spending money like mad. Anything and everything, we just get it. Okay, for example, I'll give you a small example. In my own department, in the last 3 weeks, I have spent 1.48 million pounds on equipment. So money is not a criteria for us. And despite all that, the resources are limited. We don't have endless resources. Right, let's just kind of move on to the other question. There's a little bit of, I think, Abhay asked
So the
me
most
this
important
question
part,
that,
Dr. Kumar, for the sake of all the delegates and participants, we would want to know what is new. I mean, there have been OT protocols which are standardized. There is quality control that is happening already. But for all the orthopedicians who are indulging into emergency surgeries that are going to come to them, what are the kind of differences in their anesthesia they should follow?
I'm coming to that, Vishal. The thing is, the routine work every week, Monday morning for the next week, an MDT sits in our theater complex, and which decides what cases we can operate and what cases we should not, or what cases can go ahead for the week ahead, right? And based on that, there's a surgeon sitting on that panel, and there's an anesthetist who sits on the panel, and we make the decision. Coming to that particular question, what Abhay had said, about a fracture nerve who comes to us, we have been operating fracture nerves because if we don't operate on them, their mortality is very high. It increases day by day. So we are operating on them using whatever resources we have in a sensible manner. So again, coming to that, I think the situation, the way the Indian government is dealing is, having COVID and non-COVID hospitals and places. I don't know how much of resources will be, is getting duplicated or wasted on these things. But in our hospitals, in NHS, we have a separate kind of wards for COVIDs and non-COVIDs or suspected COVIDs. And at the moment, we are dealing with every patient who comes to us, we are treating him as COVID positive, unless proven otherwise. So, and we, all the PPEs, and all the things I think have been talked about earlier. I don't want to repeat that, things like having minimum people for the anesthetic and general anesthetic and so on and so forth. So we are intubating the patients in the anesthetic in the theaters, and we are extubating them in theaters to minimize the risk. And again, when you're coming to specifically for orthopedics, when you're drilling into the bones, that is an aerolizing procedure, right? So again, you guys, all the surgeons have to wear full PPE, or else they can't be operating out there. It's quite complex. We are risking ourselves, but end of the day, that's what we do. We are all doctors. We have to take a calculated risk and keep.
I think that's a very important message, that because we orthopedicians tend to believe in a lot of wash. Pulse lavage is a norm, using drills, burrs is a norm. And I think it's a very important message that if at all we are operating, pulse lavage is completely out. Any drilling, burring is completely out. Using high-speed burrs is completely out. No pulse lavage at all. And anything that produces aerosol is completely out. All the surgeons, including the main surgeon to the primary to the secondary to the assistant to the nurse, should be using equal level of protection equipment, and they have to be standardized. They are very, very normal. And despite all this,
But again, you have to do, if a patient is coming for a DHS, then you need to do the DHS. So we take all the precautions and we take the risk and we just do it. Or else these patients will die lying in the ward. Most of these patients are elderly, they are vulnerable. And we got to take the risk.
Right. Dr. Abhay.
We have, there's a hot discussion going on the use of HCQ. And I think both Praveen and Amita will admit that it's a believers and non-believers thing. And we are still sitting on we had Zahir Udwadia's very eloquent message that day. He himself has not taken it, but Amita and myself, we both taken it. Praveen has not taken it. So I think we'll leave this HCQ controversy aside. But, going forward, Dr. Amin, do you see non-COVID positive carriers creating a big problem to a hospital? So a situation where a person has been cleared of COVID and he's been taken through the non-COVID corridor because his swab is negative, and then the hospital closed down afterwards, as happened in one of the South Bombay hospitals, because he turned out to be COVID positive. Do you see that happening as a reality?
Let's look at the PCR positive versus viral culture positive.
Now, PCR is a nucleic acid assay. So it's just assessing the nucleic acid. It may be viable virus, non-viable virus. So if you look at the period which the virus is viable, it's 4 to 8 days from the time of infection. So your window period for him to be infective would be when you get the between this 4 to 8 days, and the earlier 4 days when you can be highly infective. Once your antibody comes in, and that's where the antibody test is very important. We still haven't got that tool in our armamentarium. Once you get that antibody titer available, that means you find the antibody rising, the chances of that person being infected is less. So when you combine the RT-PCR with an antibody titer, then you'll be able to predict whether this patient is infective or not.
Awesome.
Can I come in on the
Dr.
NHS?
Amita, one other practical question. If Dr. Tushar Jumilia has to go to the casualty and see that patient with fracture hip, what is the bare minimum precaution that he needs to take when he goes and sees that patient? Or for that matter, if Vishal has to see a patient in the OPD for back pain tomorrow?
Okay, so basically the thing is that though in a lot of other countries say, and even our countries say that non-chest people could wear a triple layer surgical mask, I would say that till you don't know what the patient is having, when you're going to see an unknown patient with trauma, he could be sitting with a cough, cold, fever also, which nobody's told you about because fracture is glaring in front of the eyes. So I would say that please wear an N95 mask when you go to see the patient. If you must have eye gear, like have goggles also, you should have a gown and you should have gloves. I think the best thing would be the minute you enter hospital, please change into your scrubs. Be in the hospital all day wearing your scrubs. And before you go home, shower, wear your own clothes and go back home. That would be the best thing to do. But in the casualty, wear an N95 because you don't know what that patient is already come in with. Somebody in his house could be having fever. He could be an asymptomatic carrier. So I would say that a mask, glasses, gloves and a gown is a must.
Right.
Bare minimum.
Gautam?
So I'll give you the NHS thing. I absolutely agree with Amita. So we have now designed that every medical person has been, even the people like us who do not normally wear scrubs and roam around in the hospital, have been assigned scrubs. So you go in, you collect your scrubs, you go and change, keep your outdoor clothes wherever you want to keep them in your locker. And before you go home, you are given a dedicated blue bag where you actually put it in that blue bag, take it back to the laundry room from where it was dispensed so that it is surgically sterilized in inverted commas and boiled in the hospital laundry to get rid of it. So what our protocol for seeing a patient in A&E, everybody is query positive unless they are barn door positive. So the query positive patient, you will need a mask with a visor, either a glass shield or a pair of goggles, whichever one you choose to wear. You will wear a plastic apron and you will have a pair of gloves. If you are dealing with a patient who has the potential to have an aerosol generation, i.e. you are going to cause them pain and they are going likely to cough on you, or there is a very strong chance that they are going to be positive, you need an FFP3 masks, for which you need to be fitted well before, so that you know which size you are. You need to make sure that your filters are in place. You have those filters there, and then you wear a gown in addition to everything else, a waterproof gown with the gloves going over the gown so that you're completely sealed, and then wear a plastic apron over it so that you don't accidentally wipe your hands on something else. And if you are wearing an FFP3 full PPE setup, then there is a procedure of how you actually wear them, how you take the gloves off and the gowns off, so that in the process of taking them off, you do not contaminate yourself accidentally or contaminate others. And we have a video or doffing and donning and doffing in that process, which everybody has had to go through. It's available on our trust intranet. We look at it to revise it, and you cannot take your gloves on and off on your own. You have to do it with a pair, so somebody else can supervise you and help you taking those gowns and the FFP3 mask and everything else off at the same time.
I think it's very important that we have all been taking PPE very, very seriously while putting it on. Unfortunately, the care that is required to remove it has not been standardized, and this is something that is very important. Thank you, Dr. Gautam, for bringing it forward. That
I will try and get hold of that videos,
and we have to work in
I'll try and
pairs.
get hold of the videos and send it across.
Yeah, please do that. We'll just share it across. It's very important that when we are wearing on PPE, we need a friend, a buddy with us. At the same time, when we are removing it, there are certain protocols of donning out the PPE, because the chances of contamination are 25% higher while you're removing the PPE versus when you're wearing the PPE. So it is very important how to wear it, how to remove the PPE are very, very important. Now we move on. We are in a situation where we are 3-4 weeks behind UK and probably 6 weeks behind Australia.
Vishal, just a correction. Vishal, just a correction.
Yes,
While
sir.
putting on, you don't have the risk of contaminating because you're coming in from a sterile. So the donning process, you do not contaminate. It's while you're doffing. That's when
right.
you need to be very certain of how you need to take it off from inside out. We train all our residents to do it. We train our nurses how to do it. So there is a process which we, every new set of registrar comes in, gets that process of donning and doffing done.
Yeah, I think for all orthopods, we are still sitting at home.
Vishal, one quick thing. Dr. Amin did a very good thing in Bombay Hospital. We had trial runs for our staff and our residents. So I think y'all should, every orthopod should do that, actually do a trial run. And the place where there is doffing, we have actually a list, which again was Dr. Amin's suggestion, that one by one, what you're supposed to remove, that also has to be there, so that you don't make a mistake. So that is very important.
Important. I think it's a very, very important thing for every single person in country who's using these PPEs. Please try to follow these protocols. And I'm sure we'll love to have these videos from Dr. Amin, Dr. Amita, and Dr. Gautam. Please, if you can share with us, we'd love to share with the orthopedic fraternity to know what is the right way of doing it. Meanwhile, we are only 4 weeks behind UK, and we are like 5.5, 6 weeks behind Australia, who are in a good shape. And UK is still trying to catch up on the peak, and we hope and wish and pray that we all come to a plateau and downtrend of this. Let's hear it out from Dr. Brijen Singh, the president of British Indian Orthopedic Society, the experience from UK. Dr. Brijen, please, can you tell us about how has UK served the lockdown? There has been no official lockdown, but how have you been through the indications of surgeries? Has your indications changed? Have you started calling those so-called emergencies also now as like the non-emergency procedures like neck of femur, etc.? And your experience from NHS, please.
Thank you, Vishal, and all the people who are organizing this. Just quickly on the doffing thing. It's not that difficult. The difficult part for an orthopedic surgeon is to follow the instructions. They bloody think that they are a different human being, and
and we are often wrong, but never in doubt.
That's correct. They think that I'm going to do this my way. I'm sorry. There is no my way. There is only one way. And most hospitals, and I'm sure in the bigger corporate hospitals in India, they will have a leaflet or a poster saying how to do it. Just read it or ask somebody for help, and do not do it yourself. Now, the way we do it is, there's clear instructions, and as Gautam has alluded, so I put a plastic apron first if I'm going into ITU. And then, so the first is obviously your N95 mask, your headgear, your plastic apron, then your impermeable apron and double glove. And when you come out of ITU or theater, you take out the outer covering inside the theater and leave it there. And then the next covering goes out in a separate bag in a separate area. You wash your hands and you clean the helmet gear that is there with an antiseptic, wipe for 60 seconds as it is described, and do not feel that just because you're an orthopedic surgeon that somebody else is going to come and do it for you. I'm sorry, no, it's not like that. If you have used it, you take it out and you do it. Now, how have things changed here is that generally we have, every UK hospital has got what's called as a trauma meeting. So all the cases are discussed in the meeting there. Interestingly, since the last 3 weeks, the number of cases that are coming through have gone down because the mobility of patients have reduced and people are not going out doing their normal things. But in the meeting now, we have more than 2 orthopedic consultants who are there. So if there is any patient where there is some issues about how should this be managed, then there is more than two people, two orthopedic surgeons to advise on how they are doing. Now, interestingly, the number of beds that are, so we have about 500, 550 beds, but currently we are down to about 175 to 200 beds, patients that are in, and vast majority of them are either COVID or COVID suspected. Surgery-wise, I think one thing which Kumar alluded to, having done it myself, I think the key thing is, certainly if you are a training institute, is that this is not the time to train. You know, I've done a few surgeries recently, and after about 20 minutes to half an hour, it does get quite difficult to carry on operating. So if you've got a trainee, even if it's a senior trainee, their decision-making will be different than somebody like me who's been a consultant for multiple years. So I think that's where it's not whether they can do a DHS or not. It's a question of whether what they're going to accept and what is their decision making. That's the difference that is important. And so I think it has to be a collective effort. We're doing a lot of video calling and phone calling, and any follow-up that the patient has to come back has to be discussed with the consultant rather than the registrar just being calling for a follow-up in 3 months just for a review. And I did share out some of the BOA guidelines on this chat thing, so hopefully that will provide some information.
So I will quickly move on, Dr. Brijen. Dr. Anand, you come from some different part of NHS. So what is your experience there? Are things improving, or the surgical patients are landing up more in ICU? Is the mortality really, really high in non-COVID versus COVID patients? And what is your experience so far being with the emergency patients? Is it really worth even trying orthopedic emergencies? Because orthopedic emergencies per se, like Dr. Amita and Dr. Praveen mentioned, are not always an emergency. It is like orthopedicians' ego hedge which decides whether it's an emergency or not. So your experience on redefining the emergencies in orthopedics, Dr. Tambe.
Shivan, you may have to take it if Anand has left.
Sure.
Shivan.
Hi, Dr. Vishal. I work with Mr. Tambe here in Manchester. I think, like Dr. Vijendra said right now, the decision making as to what constitutes an emergency is being made not by a single consultant, but by a panel. Our morning spinal trauma meeting is now over Microsoft Teams. So we have all the consultants streaming in. So decision making is not by a single clinician or consultant. And at the same point of time, we have anesthetic team members there. You have to take into account the patient's comorbidities. And as you rightly said, and Dr. Amita Nene and Dr. Amin have mentioned before, that patients with multiple comorbidities, and if the surgery can wait, there has to be a frank discussion with the patient, what surgery could do to the patient in terms of exposing them to the risk of COVID. And the thing here is also that if a patient does develop COVID symptoms and they develop respiratory problems, then the decision-making regarding whether or not to even offer ventilatory support is something which is not taken lightly. I mean, not everybody who develops respiratory symptoms goes on to a ventilator. There is a very judicial use of the resources that we have. So sometimes if we're counseling patients for surgery, we have to tell them that if they develop COVID symptoms and if they deteriorate, then it might even be a situation where they're not deemed suitable for ventilatory support, and it could be fatal. So it's all a decision-making process. I think important thing is involve many consultants, many clinicians from both the surgical and the anesthetic teams, and also, as important, involve the patient in the decision-making process.
Right. Thanks, Shivan. Yes, Gautam, quick word on that.
So the most important bit is exactly what has been said. We also run this trauma meeting through Microsoft Teams, but there is something called a ceiling of care. And that ceiling of care has been decided by more than one orthopedic consultant. We have now paired up orthopedic consultants to give that, along with the anesthetist and the care of the elderly physicians. So they use something called as the fragility score, Rockwood's fragility score, which is from 0 to 9, and which takes into account the age, the comorbidities, the nature of the injury. And it has been shown that if the fragility score is well over 5, then the chances of survival goes down quite significantly. And to that, if you add COVID type symptoms, that brings it down even more rapidly. And that is where what Shivam just said, to bring in the family early and to discuss with the patient, and we have a decision on DNA CPR, that is, do not attempt cardiopulmonary resuscitation, because a CPR process is extremely highly aerosol generating, and it puts a lot more people under severe risk. And that decision is taken right from the beginning and in the community as well. So that is a very positive step that has come out from this. We are about a couple of weeks behind Vijendra in London, because I'm further north in Huddersfield, and we are a little bit behind. We expect our peak to happen this weekend coming up. So we have changed our 13-bed intensive care unit to accept 70 patients across, utilizing all the theaters, the anesthetic rooms, and we've been geared up for that. So we are expecting to get hit very hard later on this week.
Right. Thank you, Gautam. Parag, Dr. Parag, do you like, you come from one of the, Dr. Parag Sancheti, you come from one of the biggest institutes in orthopedics. Do you also recommend for the whole nation and all the orthopedician friends of yours? Dr. Parag, are you there with us? Dr. Parag, I think we are lost. So Dr. Devnani and Dr. Ram, do you also recommend conducting such kind of meetings where the indications do not have a bias, and the real-time indications can then only be operated, and all the others who can wait should actually be waiting in these tough times coming across? Dr. Devnani and Dr. Ram.
Girish, you need to unmute yourself first. Girish.
Hi, can you hear me?
Yeah.
Yeah, well, a hospital in which you operate has to be completely on board as to what they're expected to do. But we as orthopedic surgeons have to have a rational look as to what really constitutes emergency and whether we need to rush in and do every case for the fear of that patient going to somebody else down the road. That is what is the difference between the NHS system and the system that we work in here. And that is something which we have to safeguard against. I was in a hospital a week ago, and having a look at the operation register, I saw 4 cases of spinal decompression done within the last 6 days. Now, spinal decompression, emergency, 6 days, 4 patients. Vishal, Ram, are they that common, requiring emergency spinal surgery?
Actually, that's exactly the point that I'm trying to bring in, where we are in a situation where things are spreading fast, things are evolving on a wrong note. We are having more complications in patients who are operated even for the right indication. And what I'm trying to put in forward is, should we not try to triage the indications and bring in only genuine emergencies rather than the orthopedic mind wala emergencies here?
Secondly, can I just finish? When we say emergencies and when we say pre-operative, if we are assuming that every patient that comes into us is a COVID positive patient, then every patient of this nature should not be operated in any hospital which is not equipped to handle the COVID cases. I'm not saying all hospitals are Bombay Hospital level or the NHS level or whatever. We're talking about the bulk of our hospitals are smaller hospitals, ill-equipped to handle this complicated type of infective scenarios.
So Dr. Devnani, let me take this question to Dr. Amita. Dr. Amita, what's your take on that? Should other smaller hospitals which are not equipped to handle with any medical emergency not take up any of these patients?
I completely agree. I think it's a very important point, because the thing is that there is a high chance of patient having a complication if the patient is a carrier also. And in that case, if you have to sit and transfer the patient outside, it becomes quite a big thing. So according to me, it's very important to discuss all this with the patient and the relatives before you decide to take on to this patient.
Right. Thank you, Dr. Amita. Before we end, we'd like to have a word from Appaji. Appaji, you come from Chennai, from the southern part of our country, and I am told that your hospital has been following some very stringent guidelines which are already formulated in-house by your team of consultants. Can you please briefly tell us about those guidelines, which I'm going to share with the whole group around here? Dr. Appaji, are you with us?
Yeah.
Yes, Appaji. Please.
No, most of the point I've told you, we have already discussed. We have created the same way. We have a screening protocol through a single entry. And stop whatever
your
elective.
voice, Appaji, your voice is little muffled. Would you like to unmute yourself again and do it?
Yeah.
Yes, better, Appaji. Hello? Appaji, we can't see you, can't hear you.
I think his net is unstable a bit.
I think Appaji's connection is a little bit unsound.
Yeah.
No worries.
Maybe I think we can start winding this up now.
Yeah. Dr. Ram, your closing comments on this.
Vishal, can you hear me?
Yes, Appaji. Yes, we can hear you.
Vishal, the points already has been described. The Bombay Hospital group, almost similar to us, is what we have. We have a multi orthopedic hospital. The neurosurgeons are still busy with their bleeders. Hello.
Yes, listen.
Yeah.
Hello.
Yes, carry on. Appaji,
Yeah. So we are following almost all the points which Dr. Praveen and Dr. Amita have told. So we are rationing the PPEs. We are giving PPEs for all the exercises we are doing. The screening questionnaire, and there is a screen team which does that, and then the patient is let in.
Right. Dr. Devnani, your quick comment on that. Yes, Dr. Devnani, you were raising a hand.
Yeah, I want to clarify this from Amita or Praveen if they are on board. There was a suggestion that we should do a pre-admission COVID swab at home before we admit the patient. Any value or merit in that?
So, Dr. Girish, actually, frankly speaking, if the patient is asymptomatic and if anybody in the house is is not unwell, there's a very high chance that the patient would not be having COVID. Okay, so the thing is that doing a swab in this case doesn't make sense. Also, when we do a swab, there's only a 70% chance that the swab will come positive, even if the patient is COVID positive. Okay, so the thing is that doing a swab is, honestly speaking, waste of time, waste of resources, and gives you a false sense of security. So
Medico-legally, madam. Medico-legally.
Medico-legally, as of now, ICMR has given guidelines for... Just a minute.
Can I give you two?
Coming to that. No, so we have been given indications via government as to who you should be swabbing in. So the thing is that it's only in Mumbai that, like Mumbai is one of the few places where we are doing swabs privately also. Otherwise, if you go to every other state, it's only through government agencies. And for that, you have to be symptomatic or you have to be a household contact or close contact of a proven COVID patient. So the thing is that medico-legally, to do a swab on an asymptomatic patient is absolutely not required, because we are following our government.
I think we have had a day. We have had a day. We are going to have two more such days. We have answered, or rather, we have created more.
Vishal, I'm sorry, just one thing.
Yes,
and
please.
According to me, what goes against a swab is that if the patient was an asymptomatic carrier and the report comes negative, it gives the surgeon and all the healthcare workers a false sense of security, and we may be lax in taking our PPE, and it just predisposes us.
Right. I think we have Dr. Girish, we'll have two more sessions coming up in this week itself, and I'm sure this is
Vishal, can I just make a point?
Glad. Yes, Dr. Praveen.
Girish is concerned about medico-legal standing as of today. The ICMR, in terms of COVID-related patients, have actually excused a lot of healthcare workers about the possible medico-legal implications in case of ventilation, non-ventilation. So there are many issues because it's a new disease, new virus, not many new standards. So the medico-legal standing as of today, I mean, if somebody wants to take you to court for something which was not done, is still unexplained or in fact undefined. So ill-defined. What I would say is that, like Amita said, that if you do a swab for a patient with no family history of any symptom, it's very likely that you will get it negative. And the new private players who are actually doing these tests are not doctors who are doing it. Ideally, you should do it from the nasopharynx, where the yield is 60%. Whereas if you do it from the oropharynx, the yield is 32%. So your definition of doing a test which itself is, faulty in many ways, very likely that you would get a negative test.
Right. I think we are just falling in line with time, and I am sure we are not even on the surface. There is a lot more to drown in, and I am so glad that we have so many more questions rather than answers today. And I'm sure these all questions will be taken up in part 2. Before we sum up on here, Dr. Ram, to please come in with the closing comments on this, please. Dr. Ram.
Thank you very much, guys. Thank you, the very, very experienced, evidence-based and expertise-based faculty that we've had. I'm using these 3 words because we have a lack of all 3 right now, considering that this is a very, very new entity that we are sharing with each other. But we are learning as we go through. And I thank each one of you. I thank the 3 people who got it together, because these are the 3 guys who worked very hard, which is Vishal, Abhay and Ashok. Ashok Sham, Abhay Nene and Vishal Kundani. I thank the 2 members of the faculty who are seen here and been very active from the beginning, Dr. Amin and Dr. Amita Nene. Of course, Dr. Vijendra and Dr. Gautam Chakravarti, who connected from the UK. Thank you so much. Dr. Shivam Maria also connected from UK. Dr. Anand, who was there for some time, but we lost him in between. Thanks Dr. Supe, who came in, Dr. Rajan Sharma, who came in, a lot of our colleagues who came in from all over the country, including Dr. Parag Sancheti, Dr. Saraf, both of whom I can see, Dr. Neeraj Vasavada, whom also I can see, our anesthesiology team, which came in a very big way and gave excellent suggestions, both from UK and from the Ganga Hospital. And of course, a lot of our younger people from Mumbai who participated and gave in their inputs. Thank you very, very much. I just have 14 words which you got to hear me before we call it a day. The first 4 are, this too shall pass. We should believe in these 4 words. And probably the shortest 10-letter or 10-word sentence, if it is to be, it is up to me. These are 2-lettered words, and we need to understand these are 10 words. If it is to be, it is up to me. Let's all believe that each one of us needs to contribute, and we have to right now climb a huge wall, not the Chinese wall or the wall of China, but we have a huge wall to go across and get across. So thank you very much. Looking forward to seeing each one of you again on Thursday and on Saturday. Vishal, Abhay and Ashok would connect with all of us. Thank you again for being here and giving us your time and your input.
Thank you, Dr. Ram, sir. Thank you all the panelists. Before we sum up, let me just bring in a preview of our part 2 that is coming up on Thursday. We'll love to have all our panelists, and Dr. Amin and Dr. Amita. I'm just making a public request to you that you cannot be absent on Thursday. No matter how busy and committed you are, you have to keep yourself free. 4 to 6 on Thursday and 4 to 6 on Saturday, where we are going to have few more panelists coming in from AIMS, few more coming in from Chennai South. And to answer the question Dr. Sameer just very validly mentioned, what about after lockdown? We are still going to be living with Corona. How will we manage our OPDs? How are we going to prepare ourselves, and what kind of screening we have to do before we see the patients? What to do with our follow-up patients, and what is the role of telemedicine and video consulting? With this, just to echo the words of Dr. Ram, till the time this lockdown is there, please manage yourself, keep up your immunity and your spirit too. Be it through spirit or through the spirits, keep yourself high. We all do not, or probably have not, evaluated the power of human self-motivation, which is immense. We have seen Arunima Sinha climbing mountains. Just to sum it up, कारवां फिर चलेगा रास्तों पे कि फिर महफिल सजेगी, मजा भी बहुत आएगा. एक वो वक्त था जो चला गया, और अब ये वक्त भी निकल जाएगा. Thank you so much for joining us all. We'll see you again on Thursday again. Thank you so much.
Thank you.
Thanks.